Yes. Yeah.
Sure.
Okay.
Yes, ma'am.
Namaste and good evening to all the faculties. Welcome to Foxy ICOG Masterclass on Chronic Pelvic Pain, the Conundrum. So, respected President Foxy, Dr. Sunita Tanwarkar, Madam, Chairperson ICOG, Dr. Parag Viniwala, Sir, Chief Guest of today's CME, Dr. Narin Malhotra, Sir, Past President Foxy, Chairperson-elect ICOG, Dr. Sheila Mane, Madam, Vice Chairperson ICOG, Dr. Professor Ashok Kumar, Secretary General Foxy, Dr. Shivarna Khadilkar, Madam, Secretary ICOG, Dr. Sarita Bhalera, Madam, Founders of FEPA, Dr. Amita Jain, Dr. Vidya Bandukwala, Coordinator of this CME, Dr. Meena Mahalingam, and all the brilliant speakers, eminent chairpersons. So I welcome to this ICOG certified CME on chronic pelvic pain. So I think this CME will bring lots of clearance to all the doctors who have joined. So how can we diagnose and how can we treat this chronic pelvic pain, which is very common? So just to start, Dr. Meena, please share.
Yes, ma'am. Thank you.
Yeah. So
yes,
just
ma'am.
of Meena.
Thank you so much. Yes, ma'am. Yeah. I'm there, ma'am. Shall I start?
Yeah.
Kavita, madam.
Yes.
So it gives immense pleasure to be the coordinator of the ICOG Masterclass, the Chronic Pain, the Conundrum. It gives immense privilege to introduce Dr. Kavita Banwal, ma'am, who is the chairperson of the Urogynec Committee, FOGSI. Madam is a fertility specialist and consultant at Samarpan Hospital, Mungar, and she is the chairperson Urogynec and Pelvic Floor Repair Committee, FOGSI.
So, yeah, so
24 to
leave it,
27.
Meena. Yeah. So next slide, please. We should not waste time in these things. So yeah. So Dr. Meena Mahalingam.
Thank you, ma'am.
Yeah.
Yes,
so yeah.
Secretary Ogzi and Associate Professor, Chengalpet Medical College. So take privilege in requesting Kavita ma'am to introduce the session.
Yeah.
Welcome, Foxy ICOG President Dr. Sunita Tandilwarkar Madam and ICOG Chairperson Dr. Parag Biniwala Sir.
Wait. So just let me read the CV of Sunita Madam. Whether she has joined or not, I have requested her, but she may be busy.
Yes, ma'am.
But Sunita Talwarkar Madam is President Foxy. I think everyone knows how brilliant she is and how, what are the programs she has in her mind. So she is heading the Department of IVF and Endoscopic Center, Ruby Hall Clinic, Pune, founder and medical director, Solo Clinic IVF, co-founder and medical director of ELIP, Stem Cell Research and Application Center, Pune, and she has got many awards, and she is President-elect ISHA 2024-26. So if she has joined, she will bless us, otherwise we can wait for her. When she joins, she will bless. So next, ICOG Chairperson, Dr. Parag Viniwale, sir. We all know he is very humble and a good human being. She is PG teacher in Unit Head.
Kavita, thank you. Kavita, don't waste time in reading that.
Yeah. So sir has got many articles, delivered many orations. So I request sir to bless this CME so that we can move on.
Thank you, Dr. Kavita. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to welcome everyone on behalf of ICOG for the Foxy ICOG Masterclass on pelvic pain, the Conundrum. At the outset, let me congratulate and thank Dr. Kavita Barnawal who took this initiative, and special appreciation to the FEPA founders, Dr. Amita Jain and Dr. Vidya Bandukwala, who have wholeheartedly supported this program and made it a unique one. This is for the first time in ICOG we are having this program. It's indeed a pleasure to have Dr. Narendra Malhotra, who's the past president of Foxy and ICOG, as a chief guest. And the faculty chosen by Kavita and the entire team is unique. These are the people who have worked really hard in the field of pelvic pain in women. So my best wishes for the program and happy learning, everyone. Kavita, let's move ahead with the program. Thank you.
Thank you so much. So if Secretary General Shwada Madam has joined, please share CV. Has she joined? Or no, then we can move to our chief guest, Dr. Narin Malhotra, sir. When she joins, I will introduce and she will bless us. Sila Mane madam, has she joined? Okay, so
Kavita,
yeah,
invite Dr. Sarita Bhalera.
yeah,
She's
yeah.
very much
So
sure.
yeah, it's my
Let's.
pleasure to introduce Secretary of ICOG, Dr. Sarita Bhalera madam. She's consultant obstetrician and gynecologist, Bhatia, Reliance HNH Bridge
Yeah,
Candy Hospital,
Dr.
Mumbai.
Kavita, enough. Don't worry.
Okay,
Yeah.
okay. Yes, sir. Mumbai Gynae Society is
Yeah, I
president.
think
21-22. Yeah. So, madam, just say a few words, or you are chairperson in next session. So, please, just say
thank
bless.
you very much, Dr. Kavita. Thank you very much, Dr. Kavita. And I really think that this is going to be a fantastic evening. You've got such wonderful faculty and lovely topics. And this is really a very difficult area in clinical practice to manage. And I do remember that this was a casual conversation between Dr. Dheera and myself. Interesting things and talks were discussed. And I said, why don't we just have this at ICOG and let the whole country benefit from, the talks and the faculty. So I wish you all the best, and I'm sure it'll be a lovely evening. Thank you.
Thank you. Thank you, madam. So, please share CV of Daniel Malhotra sir. Yeah. So, please, yeah. Dr. Daniel Malhotra sir is very close to everyone, and he's just like guardian for me. And his CV is so long. Just I'm reading a few sentences. Sir is Director ART Rainbow, Managing Director Global Rainbow Healthcare, Director Foxy Smriti Manata, Vice President of Society for Variant Rejuvenation, Director Project Positive Health Rotary, Director International Relations Suffolk, National Director Andorra School of PhD. Sir has got many very long CV, has edited many books, written many articles, and has got so many awards like Health Icon Award, Ishar Lifetime Award, Foxy Dr. Dishi Datta Award, Foxy Box President Felicitation Award, Amar Ujala Award, and so many awards. So I think sir needs no introduction. With folded hands, I request him. He is in Hyderabad, but still on my request, he joined and accepted to be chief guest. So I request him to say a few words and bless this evening.
Very good evening to all of you. It's indeed a pleasure to be here in the ICOG Foxy Masterclass on a very, very important topic called pelvic pain. Now, we know that almost 7 out of 10 women will be reporting pelvic pain. And chronic pelvic pain is again very, very common, where they keep on coming to the clinic saying, we have pain in the pelvic region, in the pelvic lower pelvis. And remember, pelvis is a shared place. So it's not only gynec organs which are there. So there you have the uterus, the tubes, the ovaries, the upper part of the vagina, the peritoneum, the rectum, the ureters, the blood vessels, the nerves, everything is there in the peritoneum. So it's a very crowded place. And just saying that if you're having a pelvic pain, just giving a painkiller and just showing that woman away is not the right way to do. So we have to understand pelvic pain. There is pelvic neuralgia also, which is not so rare as we think. So that's neural pains. And we have to analyze all these. And today in the program, I see how beautifully structured program on what is pelvic pain, how to analyze it, what is neural pain, and then of course a panel discussion on how to handle pelvic pain. So ladies and gentlemen, I'm sure you all are going to be very, very benefited by this, because this is the commonest symptom which women come to us in the OPD. And we write only antibiotic and painkillers and shoo them away, which is not the right approach. The right approach is to reach the target or the problem of this pelvic pain and solve it at the baseline level. So all the best. Thank you, Dr. Kavita, for inviting me as chief guest. There's a big conference going on in Hyderabad, the IAHR International Congress, where Jaideep and me both are speakers here. And I have in between my talks, and I'm very glad that I'm called here and I'm being present with you all for this inauguration of this pelvic pain. Pelvic pain, think pelvic pain, think ureter, think all the others. So all the best, and definitely this will benefit everyone.
Thank you. Thank you so much, sir. Thank you. So now we will move to scientific session. So Dr. Meena.
Yes, ma'am.
Yeah, so just start.
Now we start the scientific session before time. Like to introduce Sarita Bhalera, ma'am. who's a consultant obstetrician gynecologist.
No,
Bhatia
ma'am,
Saifi.
already introduced.
Okay, ma'am. Okay. Next speaker. Nilima, can you move on? Yeah. And gives immense pleasure, Dr. Shrikala Prasad, ma'am, who's retired professor, HOD of urology and vice president, South Zone, South Sea. And she is from Government Kilpock Medical College. Her area of interest is urogynecology and female urology. She has got the best paper award in management of stone disease in pregnant patients. She has contributed 2 chapters in urogynecology simplified by JP Brothers, contributed a chapter on prevention and management of urogynecological problems by Evangel publication, contributed a chapter on urological injuries in OB-GYN practice in a book on medical legal update in OBGY. Next. Now I request the chairpersons to introduce the speaker, Dr. Amita Jain. Over to chairpersons to take over the first session.
Thank you, Dr. Meena. If Dr. Shrikala is there, Dr. Shrikala, would you like to begin?
Yeah. Am I audible?
Yes, madam.
Yes, ma'am.
Okay.
Yes, ma'am. Shrikala, ma'am, you're audible.
Yeah.
Welcome, ma'am.
It gives me great pleasure to introduce my dear friend, Dr. Amita Jain, who's a senior consultant urogynecology at the Medanta, New Delhi. She's the general secretary of the SAFUG, that is South Asian Federation of Urogynecology, founder member of FEPA, that is a real upcoming organization, a Southern Asian representative of International Advisory Board, member of the Scientific Committee of IUGA, member of the Writing Group on Female Bladder Pain Syndrome, which is in collaboration between IUGA and AUGS. She's a chairperson, Urogynec Subcommittee of AOGD, and the committee member for the National Guidelines on Urinary Incontinence of USI, of which we are all proud of. Amita Jain, the floor is yours.
Thank you so much, ma'am, for your kind introduction. Can I share my screen?
Yes, madam.
I hope you are able to see my screen. So now you are are you able to see my screen?
Yes, madam. Yes.
So, madam has joined, so we can take a few sentences, blessings from her.
Yes, ma'am.
Yeah. So, welcome, Swarna, madam. Hello.
Hello. Hello,
Yeah, Swarna, madam. Yeah. So, we have introduced you. So, just say a few words and give blessings so that we can move
I just got the brochure and I understand that this whole ICOG program is on chronic pelvic pain. Am I right?
Yes.
Pelvic pain,
madam,
the title is also very, very good. And I think the faculty that you have chosen to speak on this is also very good. And I think I always appreciate work of ICOG. Now Kavita is chairperson of Urogynec. So very appropriately she has taken this topic and she has been appointed for this ICOG work. ICOG, usually the viewership for all the programs in ICOG is fantastic and it is really growing by leaps and bounds. And we have all our videos that we do on the platform of ICOG. All the educative material is being uploaded on our Foxy website on YouTube. And the way the viewership of these ICOG videos is increasing, that now very soon the YouTube will start paying us. So ICOG and the Foxy, both of the videos which we are uploading are widely being viewed across our membership, as well as other non-members also can view our videos. And I think this is a great platform for learning for several students. And I wish you all the best for your activity. Thank you so much for having me.
Thank you, madam.
Thank you. Thank you, madam. Thank you for your time.
Vidya, you are there. I didn't recognize you.
Yeah.
Thank you, madam.
So all people whom I am not able to see, Dr. Anubha Jain, Professor
Amita.
Parde, and all of you, Meena Raghavan, I can see, Dr. Meena Mahalingam, and so many others have joined in. I'm sure it's going to be a great scientific feast for all the students. Thank you so much.
Thank you, madam, for
Thank you, madam.
allowing us to be on this platform.
So, Amita, please go on. Sorry to interrupt you.
No, no, no. Thank you, ma'am.
Yeah.
So, I'm again sharing my screen. Yeah. So, are you able to see the?
Yes. Very good.
Yes.
The lens and pen.
So I'm the opening batsman, and obviously we need to start with evaluation of the chronic pelvic pain. So it's, as everybody was talking about, it's a kind of challenging clinical entity, and actually it is a symptom, not a diagnosis. That's why there is no consensus on definition, and because so many causes are there, that we require a multidisciplinary approach to understand, to have a stepwise approach, so that we can rule out many differential diagnoses, and in this way we can actually reach to the definitive diagnosis. But to tell you that if we talk about the definition part alone, there are so many guidelines which are giving different kind of perspective, but the common thing is that usually we consider that at least the pain should be persisting for duration of 6 months. Then only we are actually labeling a patient with chronic pelvic pain. So you can see that RCOG is saying that it is not, it should be associated with periods or pregnancy, while other are like Society of Gynecologists and Obstetricians of Canada are saying that there could be associated signs of depression. So there are different definitions, but common factor is the duration. And the problem is that whether by evaluation you are able to reach the diagnosis. First of all, the patient is already suffering. It takes around 9 years for a patient to start the symptoms, and finally the diagnosis is made. And actually it makes 4 years for a woman from her first symptom to reach to the doctor. So you can see how much is the gap. And even after that, 61% of the women will not be able to reach on a definitive diagnosis. So that is the enigma of chronic pelvic pain. So what could be the differential diagnosis? I think there would be much in your mind, and we all know about the many gynecological causes, including predominant etiology of endometriosis, could be adhesions or something. Like, we are going to discuss few causes in our panel discussion as well, but it's not limited to our gynecological part. It could be from the gastrointestinal symptom, like you can see different causes, irritable bowel syndrome. If I will start reading, then it will take the whole time period. So you can see that there could be multiple factors, including genitourinary symptom, myofascial, skeletal disease, rheumatological disorder, even it could be psychological. So how to narrow down from these multiple causes to the particular cause? And mind you, if there is a possibility, there could be combination of symptoms. It's not that only pure gynecological problem is there. It could be combinations of different etiology, because there are many overlapping conditions. It has been seen that once a patient is having one kind of problem, she is prone to get other kinds of painful conditions. Like, we have seen that patients with bladder pain syndrome are also having fibromyalgia or irritable bowel syndrome. So that's why there could be even overlap of symptoms. This slide is very beautifully showing that many conditions can coexist, and that makes the picture more complicated. So that's why we have to solve the puzzle. We have to start with the history taking. So routinely we always ask for the pain history, that what was when it started, what is the duration, whether there is a relationship to the periods, or what could be the aggravating, elevating factors, quality, location, many things, and other things which we routinely do. So here the sexual history is also very, very important to, especially we refrain from asking, but this should be done like whether there is a dyspareunia, and if it is there, it is superficial or deep. So it's very, very important. And also I will tell you that how a trauma informed approach should be done. So this is a very nice mnemonic that Socrates that you can remember, so that you should not miss any point: site, onset, character, radiation, associations, and time course, exaggerating and relieving factors. And of course, the visual scale of severity. We'll talk about these things in detail. So questionnaire, yes, it will not only provide an insight on the cause, because acute lesions and inflammatory lesions tend to be more severe, but also sometimes it will give idea of the characteristic of pain, like what is the duration, frequency, intensity, all these things which we were talking about. And also if you want to do a follow-up after treating a patient, or you want to see what is the progression of the pain, then you need these kinds of questionnaire. There are so many questionnaire which are available, but the most commonly used, we all know, is the visual analog scale, that is pain score. The problem is that it is purely subjective. Suppose there is cyclical pattern of pain and patient is not having pain at the time you are taking questionnaire, then probably it seems that, yeah, she's not suffering with the pain. So that's the problem. But there are other, like the last one, that Bibroglu and Behrman scale. It is a bimodal, both subjective and objective things are there, but it is only scaling the dyspareunia and dysmenorrhea. So if suppose patient is amenorrheic, or patient is postmenopausal, or if suppose patient is not sexually active, then it's not helping. So you should actually choose the best questionnaire, or painful this scale that fits to your particular patient. So that's why we are working on one of the kind of questionnaire with the Society of the International Pelvic Pain. And actually we have translated it into Hindi, and we have modified, we have made it very simply, we have simplified it so that it could be used by our general population, and soon it will be available. Now coming to the examination part. So as soon as the patient is entering into your OPD room, you should look for the gait and posture. You can see that, this is a kind of, description. Then once a patient is into pain, then there would be a kind of, you can see that if there is weak abdominalis, tight hip flexor, tight low back pain. So it will actually shows that, yes, there is problem in the pelvis. There is pain, and it could be musculoskeletal. So you just can see by the posture that, yes, there could be a musculoskeletal pathology. Now, we from the outer side, we can see some test also which indicates the pelvic girdle pain. So just simple test, then probably you know that these patients has to be referred to a particular specialty. Like this is a Faber test, very easily done, that you can see that posture, that applying a slight pressure on the flexed knee, and while the hip is abducted, and heel is rested on the knee of the opposite limb. And if there is a pain, then probably it is a pain in the hip joint. So if this shows the musculoskeletal pathology, and it is having a very good negative predictive value. Not a very positive predictive value is not very good, but negative predictive value is very good. Other is this posterior pelvic pain provocations test. So you can see that how the knee and the thigh is being positioned by applying the pressure on the flexed knee. When the patient is lying down in the supine position, semi-flexed hip, then you can see if the pain in the gluteal region, again, the positive predictive value of this test is very good. This is a very simple test, active straight leg raising test. Again, this test is having a very high sensitivity and specificity. So these are the very simple tests. If you can ask, then actually you can see that there is a musculoskeletal involvement. And now coming to the thing that if you need to examine the patient, first on taking history, you should know that more than 3 times there could be the possibility of past history of childhood abuse, or some kind of domestic violence, which is very, very important. So very, you have to make the patient comfortable so that patient is opened up and can share these kinds of sensitive information to you. And you have to explain that probably for that if the patient is not comfortable, you are not going to examine her. So you may just have a look, you are not going to touch the private part. And there should be a very safe environment. Patient should not be like, there shouldn't be many persons who are not required sitting in the OPD room. And also if she's in between the examination, she says that she's not comfortable, please stop. Also, there should be trauma informed approach. That's mean you should use a gender neutral language, and you should actually give attention to their cultural beliefs and all those things. If there always there should be a chaperone with you, and if patient wants some of her relative, a support person, you should allow that as well. And patient body should be properly covered. Only that part which you are going to examine should be exposed. And there is a tendency of our like we always ask patient, relax, take a deep breath, relax. Please don't avoid these kinds of triggering words, because it gives a opposite reaction. Patient will start squeezing more, so it will be difficult for you. Then start with the visual inspection of the external genitalia. See for the any, if postmenopausal, any trophic and sexually active, then probably any lesion, fissures, or abnormal discharge. And then a simple cotton swab test. And you can see that how it is being done. And you have to serially apply to labia majora, prepuce, clitoris, interlabial sulci, and labia minora, and the vulval vestibule in a semicircle fashion from lateral to the urethra to the posterior fourchette. So in this form, once you're doing, then you have to see patient's face, and then you can actually score the pain from 0 to 10 VAS pain scale. And actually at every point you can give a score, and then you can pinpoint where is the maximum pain. Now, on starting examination, never introduce the full hand. Start with a single glove digit so that patient feel comfortable, and then you can actually palpate things one by one, by urethra, then inserting more inside bladder neck, then bladder gently palpated on the anterior vaginal wall. And in this way, you can actually proceed towards the posterior wall and lateral wall as well. And also on the posterior wall, you should ask patient to contract and relax the pelvic floor muscles and see whether there is any asymmetry, limited mobility, or even paradoxical relaxation. So these things should be done. And never do a bimanual examination, because you won't be able to judge separately the bladder. And the thing is would be that if there would be, there are many things which you can understand whether it is from uterus or from the bladder. But if you are doing a bimanual examination, it would be difficult for you to elicit whether it is coming from the bladder or not. So for the bladder, it's better with the single glove. Now, see for the superficial transverse perineal muscles, which is at the vaginal opening under the hymenal remnant. You can see all these muscles, which is very beautifully, shown in this diagram. Then for the deeper palpation, go for levator ani muscles. And you can see the numbering here, and you can take a photograph of this PPT, and you can see how, you can elicit one each and every part of the levator ani. And you should palpate at the 5 and 7 o'clock position, approximately 3 to 5 centimeter inside the vagina, to just palpate the puborectalis and pubococcygeus, which is the main part of the levator ani. Okay. Here it is shown as 1 and 2. Now, to see the obturator internus, this should be the position that you have to hook the digit around the pubic rami and having the patient abduct their knee against the examiner's external hand. You can see the position, and then you have to apply a pressure around of 2 kg, and then you have to just palpate and see if there is a pain or tenderness on the muscle. It is an abnormal finding. So that's mean there is a problem in the obturator internus muscle. Now coming to the speculum examination, we know that what we have to do here. Always again, if again patient is very sensitive, then use a cotton swab to examine the pressure point and tenderness. And it's very important here, because putting a finger sometimes can elicit so much pain that you won't be able to pinpoint the particular point where the pain is starting. Bimanual examination you can do right now if you just have palpated the bladder and everything. Now you can, if there is no pain at that time, now you can see, and then in this way you can differentiate whether it is coming from the bladder or it's somewhere else from the uterus or abdominal wall. The rectovaginal examination, again, to assess the deep infiltrating endometriosis and rectovaginal nodule or uterosacral ligament disease. Now coming to this investigation part, again I am telling you that after looking on the history examination, there would be some indications that what investigation you should look for. So there could be battery of investigations, and I am telling you the imaging studies are very helpful. But again, there should be a judicial use of these kinds of things. Like if you want to see the bony structure intestine, then probably CT is better. But for soft tissue abnormalities, MRI is better. And you should avoid these urodynamics and anemanometry on the first hand, because these tests can provoke the pain. So there should be a judicial use. As it is like this is a slide which is showing that in the patients with pelvic congestion syndrome, on CT and MRI, you cannot make the diagnosis unless until the patient is having 6 months duration, and the radiologist must be cognizant of the established criteria to suggest this diagnosis, like the diagnostic criteria: 4 or more ipsilateral pelvic varicosities, 1 or more pelvic varicosities measuring more than 4 millimeter, and ovarian vein dilatation more than 8 millimeter. So it's very easily written pelvic congestion syndrome. So there is a certain criteria which you have to tell your radiologist what you are thinking of. Then only they should report the diagnosis. And otherwise patient will be after you that yes, this is the diagnosis made, and you won't be able to do the justification. Now coming to the endometriosis, and you can see very nicely that for endometriosis, the ultrasound is as better as doing MRI. So you can diagnose many things on ultrasound, and there are many signs. I cannot go into detail. There should be a separate lecture for that thing, but many things can be diagnosed on ultrasound. Role of diagnostic laparoscopy, yes. When chronic pelvic pain is so severe, and after doing all these preliminary investigation, nothing is found that probably you should go for a diagnostic laparoscopy. It should be a collaborative decision, and the thing is that we think that mainly the chronic pelvic pain could be because of the gynecological cause, but studies have shown that GI and urinary causes are also very common. So you can see in this slide that the urinary causes are also almost equal to that of gastrointestinal causes. And if we talk about our gynecological system, the only the cause, the percentage is 20%. So that's why you have to be very vigilant about the thing. That's why unnecessary laparoscopies should be avoided, and also unnecessary hysterectomies, because it has been seen that mostly if chronic pelvic pain is there, uterus is the culprit, and it is being removed without thinking that if the patient pain is not relieved, how will you save your face in front of the patient. So it happens many times that patients are coming to us that yes, uterus has been removed, but still pain is not. And what could be the cause of these things? Sometimes the pain starts from one organ, but there could be a connection, like you can see viscero sensitization. So the pain starts from one organ, but it is felt in another organ because of the similar nerve supply or sensations. And you can see that's why sometimes the referred pain could be through peritoneum, and it can be felt in far places like the culprit is in the middle in the bladder, but the pain is felt in thigh, or pain is felt in the upper abdomen. So you can see that that's the reason sometimes that we are removing the target organ, even then the pain is not getting relieved. And also there is a phenomena of central sensitization, where you can see that the pain is a kind of thing which is taken by the brain. It is taken like it's a normal sensation, and that's why if even the disease is being cured, then the pain would be persisting, because brain is taking it as a kind of normal sensation for that part. So these are the very important thing. And you can see that referred pain can be seen as a cutaneous hypergesia, allodynia, or myofascial trigger points. I think Dr. Mahesh Menon will be describing these things in detail. So there could be some tests for central sensitization as well. And I am not going into the detail of these things, because I think Dr. Mahesh Menon is going to cover these things. So the only thing is that there could be questionnaire. Cutaneous allodynia is very, very important to be ruled out by the cotton tip applicator test. And these tests, though hyperalgesia and trigger points can also be elicited by simple tests like Carnot test or abdominal vaginal pain threshold allogometer are available. But now people are working on the brain studies. So directly looking on the brain, cerebrum, and gray matter. So these are the new roles of brain neuroimaging. This is called functional MRI. And you can
Dr.
actually
Amita, I think we're going to run short of time. Can I request you to wind up?
It's the almost last slide, ma'am. So these are the things which are coming up, and you can see red areas. So these are the things which are coming up, and there are some multimodal hypersensitivity derived from quantitative sensory testing pedicles. These are the tests which has been introduced, and the studies are going on which are showing that you can see that visual, auditory, bodily pressure, these things can be you can see the indirectly that these patients are going to develop pelvic pain in future. So these are the new studies, and you can look for these papers to see that what are so just to wrap up, so whenever patient is coming to you, just give her a questionnaire and give the information about the disease. Then it's better that this should be the before the first visit, that your coordinator should provide these kinds of things. Once the patient is with you for the first time, detailed history, as I explained to you, it should include family history as well. Discuss the patient's answers for the questionnaire, which has been already been done, and then examination part, which I already described to you, and simple investigations. So MRI and all those things are having limited value. Once the follow-up visit is there, and if you have confirmed the diagnosis, then your point is that pain course should be seen in progression, so that whether patient got relief or not. So with that, I'm concluding, and I think for evaluation we need patience and time, not only of patient, but our patience is also very, very important. So it's very, very important that family counseling, giving time to the patient, keep these OPDs a little longer, not only 15 minutes. Like my lecture is only of 15 minutes, but I cannot finish all the things because it's a very vast subject. So I'm just skipping these things, that there are some special populations which should require, these are the special populations which require special attention. So thank you so much. I think this is my take home message is that never leave these patients feeling that nothing more can be done. Never say that, because I have seen that many patients are telling me that I have been told that I have to live with this pain lifelong. Nothing can be done. So please be optimistic with these patients. Thank you so much.
Thank you very much, Dr. Amita. That was a wonderful talk and really sensitized us and to the whole concept of chronic pelvic pain. You brought out beautifully how we need to counsel and take time and really get to know the patient, and not to just tell them that there's nothing wrong. I think if there are any questions, we can have them in the chat box and we'll move to the next speaker because we have two other speakers now in this session. It gives me great pleasure to introduce my friend Dr. Meera Raghavan. Dr. Meera is a consultant urogynecologist and robotic surgeon, and she's from Chennai, and she's the secretary of the Chennai Menopause Society. She's done a lot of work in urogynecology. She's also worked with the IRC, that is the India Representative Committee of the RCOG. She's a member of the Specialist Committee of the National Board of Examinations, an MRCOG trainer and examiner, and has many, many publications and gold medals. So Dr. Meera, over to you for the next part of the discussion.
Thank you, Dr. Sarita, for the kind introduction. Are you able to hear me better now? Yeah.
Yes, we are.
Madam.
And can I share? Am I allowed to share?
Yes, you can share,
It's
ma'am.
not. Okay.
Meera, this is your MCQs?
No.
Meera, is this the right one?
It is. You're seeing now. Can you see now?
Can you put it in slideshow, please?
I have.
Madam, you're seeing your MCQs.
No, I'm sharing now. It's paused. Somebody's saying it's paused.
Meera, I was just wondering, these slides are MCQs. Are you putting that?
Ma'am, I'm sharing the full PowerPoint, but somebody has paused my sharing.
Okay.
Gauri, please see what has happened to the sharing.
Nilima?
Yeah, Nilima and Gauri are handling it.
Support team ICOG, are you there?
Can you see now?
Yeah,
yes.
Now it's perfect.
Thank you. So, my topic, which has been given today, is bladder-centric pelvic pain, which I'm going to concentrate on important aspects of evaluation of bladder-originated pelvic pain. So, can be perceived due to a bladder-related issue and often presents with a triad of pelvic pain, urinary urgency, and frequency, the famous PUF triad. And it does leave a major impact on women's quality of life, and it is definitely a diagnosis of exclusion. And I want to emphasize a multimodal approach and a multidisciplinary management is the key to successfully treating any patient with a bladder-centric pain. Now, chronic bladder pain or discomfort with urinary symptoms encompasses the whole definition of bladder pain syndrome, and pain or pressure basically while filling of the bladder perceived to be bladder related, duration of more than 3 to 6 months as per the National Gibbs guideline. There should not be any infection or identifiable cause like a bladder calculus or a granuloma, which is causing the pain. And interstitial cystitis is pathognomically identified with the presence of what we call Hunner's lesions, which are stellate ulcers with variegated appearance of vascularity in the periphery when we see them at cystoscopy. And it can also be present without Hunner's lesions. So the incidence in women is about 2 to 6%, slightly higher than what we see in men. Middle age seems to be the time when there is a higher preponderance of bladder pain syndrome. Unfortunately, it's often underdiagnosed or misdiagnosed like any other pelvic pain syndromes, or even the patient is blamed to be having all in her head and kind of feels very dismissed or not listened to adequately. High rates of comorbid pain syndromes associated with the chronic pelvic pain syndrome can exist alongside bladder pain syndrome. So always look for features of endometriosis or irritable bowel syndrome, because nearly about 40% of patients with interstitial cystitis or bladder pain syndrome can have coexistent endometriosis. There is unfortunately a significant delay between the symptom onset and diagnosis, and patient keeps going on from one specialist to another without the diagnosis, and therefore without not any proper management, and patients become centrally hypersensitized to the whole pain stimulus. This basically emanates from a urothelial dysfunction, thereby attracting mast cell activation and influx into the bladder urothelium and causing and setting up a cascade of neurogenic inflammatory reactions within the bladder urothelium. This further goes on to set up a central and sensitization and a pain amplification. There are various autoimmune factors which play and cause disruption of the mucoprotective layer, otherwise known as the glycosaminoglycan, the gag layer of the bladder urothelium, thereby exposing the nerve endings alongside the bladder urothelium to further insult and injury by any triggers which can be present in the urine. And it is also further exacerbated by psychosocial factors, especially lack of sleep and stress-related issues. It can have a serious overlap with other chronic pain conditions, therefore making it difficult to diagnose and manage adequately. In the interstitial cystitis subset of bladder-centric pelvic pain, there is more inflammation in the bladder, and whereas the bladder pain syndrome without the Hunner's lesion has more neuropathic or a pelvic floor hypertonicity and a functional aspect to the entire pain physiology and pathology. So what are the clinical features which could kind of be the markers for anybody to find out whether this patient could be suffering from bladder pain syndrome? They have a very dull ache and a kind of pressure building up in the bladder area where the bladder is filling, feel some degree of relief when they empty the bladder. Pain worsens with the bladder filling. Urgency and frequency are notoriously seen in this patient, more so night frequency, where patient's sleep gets disturbed. Dyspareunia, dysuria, sometimes even difficulty in emptying the bowel, and pain radiating to the perineum or the thighs as if they are sitting on something very tight down below. And symptoms fluctuate and may worsen with stress or certain triggers in the foods, especially caffeinated drinks, spicy items, processed food, as well as anything which contains the food coloring or the food flavoring. Wine and chocolate are also notorious. What could be the possible pathophysiological cycle? There is definitely an insult to the bladder which causes urothelial dysfunction. There is a leakage, as I said earlier, because of the disruption of the mucoprotective layer, and that aggravates stimuli into the C fiber, which gets activated, and release of the dologenic substance P, and that causes an influx of mast cell and activates the histamine release and more injury. Because of this mast cell activation and histamine release and the association of other allergic tendencies in a particular woman, hydroxyzine would be a choice of medication which could come in handy for the management of bladder-centric pelvic pain. So I'm trying to correlate the pathophysiology to the medical management which we do in these patients. What are the diagnostic criteria? Chronic bladder pain and discomfort existing for more than 3 months, associated with urinary symptoms, whereby we have excluded any cause of infection, stones, or malignancy, and cystoscopy for atypical cases or hematuria. So cystoscopy is not a must to diagnose interstitial cystitis or bladder pain syndrome. However, we use cystoscopy with a therapeutic intent to deal with whatever lesions we are seeing at that time, and also to exclude sinister causes if there is a red flag sign of hematuria, mainly to rule out GU-TB in our subcontinent and carcinoma in situ. If the patient has history of smoking or tobacco usage of any nature, please go ahead with the cystoscopy with the therapeutic intent at the outset itself. So the initial evaluation, nothing to replace a detailed medical and gynecological history, bladder diary and symptom scoring. We have validated questionnaires with visual analog scores. Pelvic examination, do refrain from doing a speculum examination, build up a rapport with the patient, have a systematic way to assess the pelvic floor, the perineum, the external genitalia, look for any tightness or spasms, especially in the lower part of the abdomen, the thigh, the gluteal area, and as Dr. Amita Jain already has displayed in her slides, have a systematic evaluation of the musculoskeletal system as well. Now, the pelvic floor is bound to be tight, and we will be able to appreciate what we call myofascial bands. These are taut bands in the pelvic floor, which keep the pelvic floor really tight and under spasm, and thus can cause a significant pain in this patient when they have, especially not the interstitial types, but the bladder pain syndrome kind of neuropelvic origin of the pain. Urine analysis and urine culture are must to rule out infection, GUTB, and carcinoma in situ, and definitely consider cystoscopy if the atypical features are present, or going in with the therapeutic intent. I always do the O'Leary-Sant questionnaire and the Puff Triad questionnaire, not only to assess the symptom, but also to assess the severity of the problem. Differential diagnosis will be bladder cancer, bladder stones. Vulvodynia, endometriosis, and dysmenorrhea are not differential diagnoses, but should be sought out as coexisting factors when they present with bladder-centric pain. Because of the frequency and the urgency, it can be confused with overactive bladder, but overactive bladder will not have pelvic pain and pelvic floor dysfunction. So neurological and gastrointestinal causes, especially irritable bowel syndrome, can be mistaken for bladder pain syndrome. So what about the role of cystoscopy? As I mentioned, for the red flag signs and for therapeutic intent when you suspect Hunner's lesion, where you can actually fulgurate the Hunner's lesion or resect the Hunner's lesion. And bladder pain syndrome either can present with a completely normal cystoscopic finding or glomerulation where there is an absence of any particular characteristic Hunner's lesion. So patients present with various phenotypical presentations, they can present with Hunner's lesion, which is more inflammatory in nature, or without Hunner's lesion when they are more neuropathic in nature. But there can be overlap of the pain syndromes, and allergy or autoimmune based is also seen. Basic principles of management will be shared decision-making with the patient, a stepwise and multimodal approach. Begin with the least invasive options, regularly reassess the efficacy and the side effects of the medications which we are dishing out, and refer to multidisciplinary team if needed. And I would do it at the very outset, and I strongly believe in what we call pelvic floor rehabilitation. Now, unfortunately, whenever we mention pelvic floor, everybody assumes it's pelvic floor contractions and Kegels. Kegels are contraindicated in patients with chronic pelvic pain syndrome, especially the neuropathic type when associated with bladder-centric pain, because this worsens the pain component because of the pelvic floor becoming taut. They need to practice what is called pelvic floor relaxation, ballooning of the pelvic floor, or reverse Kegels, and that has to be incorporated in the initial management of the patient. So anything which relaxes the pelvic floor, either medically or in the form of pelvic floor relaxation with biofeedback, is something we need to think out at the very outset. We normally give them leaflets about patient education and set their expectations right. When I tell these patients, I say there is a flare and there is remission. Similarly, when an asthma patient is asked to refrain from ice cream because ice cream will worsen asthma, patients with trigger in their food and diet will have exacerbation. So it is better to avoid those foodstuffs till we get on top of the healing process. Bladder training and timed voiding helps reduce the frequency and the urgency. Stress management techniques and pelvic floor physiotherapy. That is why I mentioned pelvic floor rehabilitation. Putting them to support groups and liaising with people who have conquered the problem, they will be able to deal with the issues better, and counseling is part of the therapy. Amitriptyline as a neuroleptic is a first-line oral agent. We do use gabapentin or pregabalin. Word about pregabalin, be aware of the weight increase or the weight gain which they can be if they are chronically put on pregabalin. NSAIDs, acetaminophen for pain control. Hydroxyzine for patients with allergies and mast cell involvement as it itself an inflammatory process. Avoid antimuscarinics because this is not overactive bladder, because these patients can have voiding difficulty because of a taut pelvic floor, and using antimuscarinics will precipitate an episode of acute retention and a need for catheterization. Pentosan polysulfate is used orally, but we'll have to make sure it is done for a period of at least 3 months to see visible effect. It should be avoided in patients with low platelets or rectal bleeding, and patients to take it 2 hours prior to food or well away from the meal time to increase the bioavailability. As such, oral pentosan polysulfate does not have greater than 10% bioavailability. Inform your patients to store it in the fridge door because otherwise it loses its efficacy as well. We now have intravesical preparations, which increases the bioavailability of the pentosan polysulfate to increase the replenishment of the gag layer. We can use lidocaine as an analgesic agent and heparin to replenish the gag layer. These have to be given repetitively to replenish the protective layer. We use botulinum toxin injection intravesically for refractory cases. This is one situation where we would inject the botulinum toxin in the trigone area where there is a plethora of the nerve endings and thereby desensitize the bladder to the frequency and the urgency as well as the pain sensitization. Neuromodulation is also known to be helpful in carefully selected cases of refractory interstitial cystitis for it to be successful. And hydrodistension under anesthesia, not for more than 2 minutes, with an appropriate height of a column of saline, and which has to be done under anesthesia. Never perform a cystoscopy under local anesthesia because that will trigger off the pain cycle. And we have the step ladder pattern of treatment of bladder pain syndrome. In summary, there are multiple treatment options, and treatment will depend upon the severity stage, and a multimodal approach is the key to success. Avoid long-term antibiotics, oral steroids, and use of long duration high pressure hydrodistension because this disrupts the bladder, and never use intravesical BCG. Regular symptom reassessment with validated questionnaires and tools, or just therapy based on response and side effects. Monitor for complications and encourage ongoing patient. Gynecological perspective, misdiagnosis risk is always there, and I've seen patients who have unnecessarily been subjected to hysterectomy as usual, the uterus being blamed as the origin of pain, and the patient still continues to be in severe pain. And the Taiwan cohort study, women with ICBPS had a higher risk of hysterectomy. Overlap with gynecological disorders is also something we need to bear in mind, and uterosacral ligament repair can relieve pain, urinary symptoms in selected women. And pelvic floor defects may underlie some of the ICBPS cases as well. Again, avoid the specular, phenotypic-driven approach, avoid unnecessary hysterectomy, and a comprehensive
Ma'am, sorry
assessment.
to interrupt you. Your time is up, ma'am.
Yeah, this is the last slide. We have a lot to do in microbiome research and do personalized phenotype-based therapy, and research is important to further enhance the treatment, and non-pharmacological incorporations of pelvic floor physiotherapy with biofeedback, cognitive behavior therapy, and pain management. And thank you for the lovely opportunity. Thank you.
Thank you, Meera. That was really excellent, and you did a wonderful job. You covered the entire disease. I know you need more time, but it was really excellent. Hats off to you, Meera.
Thank you, ma'am. Thank you.
Yeah, thank you, Dr. Amita and Meera. Both batsmen did very well. So thank you so much. Now, please invite another Meena. You are there?
Yeah, I can see her.
Yes, madam.
Yeah.
Yes.
Yeah. So,
Request
Srikala
the
madam,
chairpersons to introduce next speaker, ma'am.
Dr. Mahesh Menon. Srikala madam, please introduce Dr. Mahesh Menon, sir.
Yes,
Share CV of Dr. Mahesh Menon, sir.
we have, yes. We are happy to introduce Dr. Mahesh Menon. Just please put that CV. Yes. Dr. Mahesh Menon is a director of the High Bright Pain Management Solutions, an advanced multi-specialty hospital in Mumbai. Andheri West has got multiple centers, Mangal Anand Hospital, Chembur, and lots of other places. He is also attached to the Sir H.N. Reliance Foundation Hospital and Research Center, which is where he's a lead in pain and palliative care, and also is attached to Kokilaben Dhirubhai Ambani Hospital, and his list is continued. Welcome, Dr. Mahesh Menon, to give your expert opinion on this important topic.
Thank you. Am I audible and visible?
Yes, your slide is showing the thank you slide, but
Yeah, because I always start with a thank you slide, madam.
that's wonderful.
Yeah. So this is one of the things that I like to do because in the end, otherwise the background music starts ringing and people say my time is up. So I can't thank people. So it's better
That's
to
a
thank
nice
in the
point.
beginning for this
Okay.
great opportunity. And I had a very nice time interacting with the team at FEPA also recently. It was good. And Meera madam also helped me with a practical demonstration of central sensitization, which unfortunately is difficult to do online. So I have no conflicts of interest to declare. I'll try and keep this as simple as possible. So those of us who are listening to this particular talk will realize that there has been a lot of overlap of what I am going to be saying with what the previous speakers have beautifully highlighted. So it'll be more like a summary slide for everyone. So I'll start without further ado. I'm just going to break it into 4 parts. First, I'll talk about what is pain. Then I'll talk about the pain pathways. Then I'll talk about the topic at hand, with this central sensitization and the therapeutic implications of it. So this is just for the sake of completion. We know that pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. In summary, this is something that one of the previous speakers has also mentioned, that there may be tissue injury or there may not be tissue injury, yet the person may feel pain. So this is one of the quirks of the neurological software of pain, because it's a protective signal and sometimes it may misinterpret signals and cause the person to experience pain. Now, this is basic physiology for all of us who have done medicine. Whenever there is a noxious stimulus and it activates the higher centers, it is called as pain. So these are the higher centers from below upwards: the peripheral nerve, spinal cord, the medulla pons, midbrain. A lot of research has focused around the peripheral nerve. So most of what we know in pain medicine deals with the peripheral neural apparatus. But if you look at it in detail, it is actually a noxious stimulus transduced by a nociceptor. And nociceptors are of 2 different types. The signals are carried by nociceptive afferent neurons. They go to the spinal cord, they form their own tracts, they converge in different area of the spinal rexid laminae onwards, and then they go to the higher centers where they relay in different centers. So the neurological apparatus is very complex, and it does not subserve only one function of nociception. There is a lot of other things that happen, because once it's activated, it also has to ensure protective downstream reflexes. In fact, the protective value of pain can be seen in children who have mutations where they have congenital insensitivity to pain. So much so that the children don't feel pain and they get auto amputation without even realizing that pain, there was tissue injury. Leprosy, for example, is one of those conditions where there is damage to tissue. So pain is a useful signal. However, in our branch, it has to be understood in the context of the person, which I'll come to. So in central sensitization, you've heard this term. It just means there's an increased responsiveness of these neurons to their normal or subthreshold input, which means if there is a painful signal, it is amplified. And if there's a sub-threshold signal, it is carried over, it is caught. It should have been ignored, but the body is not ignoring it, unfortunately. What are the effects of sensitization? The nerves can fire spontaneously. This is an ectopic neural impulse. The nerves can fire spontaneously. There can be increased sensitivity to stimulus. As I mentioned, you can have another signal which is transduced as pain, which is called allodynia. A non-noxious signal is perceived as a noxious signal. You can have hyperalgesia, which means a painful response to a pain stimulus is amplified. There's an increased perception of pain, and there's a reduced inhibition of painful signals by the normal functioning neural apparatus. So if there is tissue injury, there is a disinhibition of the surrounding nociceptive neurons, which means that they're able to fire a lot more. Anytime a patient comes to your OPD and they are not able to understand this, just try and explain to them the concept of a busy road, where you can see the pain fibers going in as busy trucks and normal signals going like motorcycles. So if you have motorcycles which are zipping past fast, the trucks can't travel. They have to slow down because they have to be very careful. But if there are no other vehicles there, then these trucks can keep going fast on the highway. This is something that happens with pain. They get a free way, they get a free pass to go, but there's no obstruction by other signals, so they can keep traveling fast. How do we use the pain pathway? I mean, how does all of this make relevance for, we are clinical practitioners, we are operating, we are busy seeing patients, and we have hectic OPDs. How does this basic science topic make sense to us? So a small example, cold sensitivity is through transient receptor potential vanilloid receptors, which means some people may have thermal sensitivity to pain. Some people may have mechanical sensitivity to pain. So you can ask, if this person gets pain, which is spontaneous in origin, you definitely know that the peripheral apparatus has been bypassed. There is something that is happening from the spinal cord level upwards. If it is evoked, which means there could be some pressure effect, the viscous could be dilated, there could be intercourse, there could be pressure, there could be activity. It could be a mechanical stimulus or it could be thermal stimulus. In each of these, there is an overplay of mechanisms. Thermal sensitization is a part of peripheral sensitization. Central mechanisms play a part in spontaneous pain signals. And if it's mechanical, there is an element of both central sensitization and peripheral sensitivity. So it's very difficult for the body to say that I'm going to take care of the central pains, you take care of the peripheral pain. It is like GST, both state and center, both will levate. So it is something like that. Coming back to this, let us talk about the practical implications. Again, we are clinicians. Now we are going to be seeing patients. How do we make sense of central sensitization? Take a pain signal that's been there for an acute duration, like a few hours. It's like post-operative. And you look at this patient, their blood pressure is high, they are tachycardic. Imagine this state continues for a few days to a few weeks. There's a chronic stress response. Now imagine this happening over months to years. Now in a woman, imagine the impact of pain on their physiology. What must be happening to them? Of course, with the stress response going up, being bedbound. Then look at the impact on the body. Look at the impact on the mind of the person. Look at the impact on their family life, their social functioning, and so on. So you can imagine how many layers this is affecting. For example, if they are not able to function normally in their homes, they're not able to take care of their families, they're not able to take care of themselves. So imagine the impact that is happening. So it's not just that neural axis between the spinal cord to the cerebrum, it's also the output. That is why if you notice in the first talk, the pain measurements were also measuring impact of pain, not just the pain intensity, like a 1 to 10 scale impact. They were also measuring other parameters like the impact on the patient's quality of life and living. So the solutions, coming to the last part, this is where I make a sales pitch and say that you can contact me or you can contact a pain specialist in addition to your routine steps that you're already using for management. Meera madam mentioned something about neuromodulation nerve blocks. So I'll just cover those and try to see how we can deal with central sensitization. So the simplest formula is to desensitize. If there is a central sensitization, desensitize. So how are we going to go about it? So we need to reduce the pain signals that are going in. We need to improve the mood, improve sleep, improve function. Because now With time, if there is an impact on their mood and there is reactive depression, you need to give them medications for that as well. Meera madam mentioned muscle-based treatment because these areas, myofascial triggers, can be sensitized. You need to have relaxation strategies and ultimately end organ related treatment where you are the experts. So you know what to do. So the interventions and medications that we propose, neuropathic pain medications, we follow protocols to give neuropathic pain medications, which work on different channels. So you can have things that work on the calcium channel. You can give some things that work on the sodium channels. We can have different options, but they have to be done as a part of a team. At higher levels, above the level of the midbrain, you're looking at medications, which are the antidepressants and the tricyclic antidepressants, like for example, SNRIs, which help with pain. Finally, at the level of the cerebrum, it's cognitive behavioral therapy, because interestingly, when it touches the brain, when it touches the cerebral cortex, that is when it is perceived as pain. So pain is actually a thought process. So you need cognitive behavioral therapy to help with cognition and to help with behavior. So whenever your patient tells you that, doctor, my pain is a terrible type of pain, the word terrible is not a sensation like pricking, poking, burning. It is a thought process. It's an emotional descriptor. That's why when a patient says my pain is terrible, the descriptor that matches them, the area in their neuraxis which is acting up is the central one, which is the cortex. So you can use descriptors and just assess if the pain has already become central or not. What are the things that we do? The CBT helps with coping, ensuring compliance with treatment, improves mood and affect, restores function, which is a positive, which gives them that impetus to keep doing their treatment and getting better. The nerve blocks that we specialize in, we can give peripheral nerve blocks, we can put in central neuraxial blocks, we can do neuromodulation or do intrathecal drug delivery. In addition to this, we may use probably virtual reality or nuance. There are experimental strategies that we can use. We use lignocaine ketamine infusions in certain patients, in fibromyalgia at least. There are different things that we may try as pain specialists to help our patients deal with chronic pain and get back to a decent quality of life. So if I were to summarize all of what has been said before, pain may exist in women with or without overt signs of a pathology. Like all the tests are normal, yet I have pain. There'll be neurological mechanisms that contribute to persistent pain, and we have understood how the nerves can carry a simple signal like pain and make it complicated. This can happen because of central sensitization, which can contribute to significant morbidity. The longer the pain remains untreated, the more anxious the person is. If there's an underlying metabolic problem like diabetes, thyroid disorders, the pain can be, the sensitization can take place. If there's a history of trauma, history of abuse, pain can be, central sensitization can take place. And multidisciplinary approaches help people with chronic pain. So if these last 2 points can be understood, I think we can all make a massive difference to the lives of many women. As the first speaker also mentioned, that most of the patients suffer for a long period of time before they report to a gynecologist. So imagine, as a male pain specialist, how much this patient must have traveled before they have reached us. So this is something that I would like to stress upon, that use an MDT team and get a neurologist, rope in someone so we can make sense of that for the patient and guide them along the treatment journey. Yeah, thank you everyone. And I decided to stop much before the music, like the Oscars. These are some of the references.
Thank you so much, sir. On behalf of the ICOG Masterclass, like to thank the speakers, Dr. Amita Jain, Dr. Meera Raghavan Madam, and Dr. Mahesh Menon, sir, and also the chairpersons for the first session.
Can
Dr.
we
Shrikala
just
Prasad Madam
thank
and
Dr.
Dr.
Mahesh Menon? I think we didn't get a chance to do that. Yeah.
Yes,
I
yes,
think,
request the chairpersons to
yeah. So I just
thank.
like to thank Dr. Mahesh Menon for a wonderful talk. It was very nice. And maybe Dr. Srikala might want to say something because we have 1 or 2 minutes.
I really liked concept that we must totally evaluate the persons, how much of time the patient is lost before they actually seek the correct treatment. So we must all of us must take, we cannot have enough number of a lead person in pain medicine. So all of us must rise up to the occasion, do a more good hearing, listening to the history, a detailed examination, be empathetic to the patient, and then do appropriate investigations and management. And I liked our speaker say that don't disown them. They should never go with the idea that they have to live with that. So that, I think, is a very good take home point. If all of us start doing it, I think it will be a great job, a great service to our women as a whole.
Thank you, Sarita madam. Thank you, Shrikala Prasad ma'am, for chairing the session. And now we move on to the MCQs. Do we have time for MCQs? Kavita ma'am? Kavita ma'am?
I think you move to the next session, no?
Yeah.
Yeah.
So now
Because
I'd like to introduce the chairpersons of the next session, Dr. Karishma Daryani, who is a consultant, Center for Urogynecology and Pelvic Health. She is a member, Education Committee IUGA, member, Prolapse Committee IUGA, reviewer for International Urogynecology Journal, Indian Pediatrics, author of various chapters in gynecology and urogynecology. She is the assistant professor at Lady Harding Medical College. Next, like to introduce Dr. Rajesh Kumari, who is additional professor, obstetrics and gynecology, and her areas of interest is oncology, urogynecology, and pelvic reconstructive surgery, high-risk pregnancy from AIMS, All India Institute of Medical Science. Next, Dr. Dheera Samdarya, who is a consultant gynecologist and urogynecologist, Jeslok Hospital and Bhatia Hospital, Mumbai, scientific coordinator in conference, Urvashi, Urinary Rectovaginal Health and She, an annual urogynecology conference, KMC Manipal, January 2023. She is a guest faculty at Urogynecon. Over to the chairpersons to take. Her publications are Awareness and Attitude Towards Aesthetic Gynecology Among Gen Next in India Direct, Easy and Educational Sacrospinous Ligament Fixation, an Innovative Technique for an Age-Old Procedure. Her interest is to develop a dedicated team in urogynecology and pursue it as a specialty and be instrumental in improving women's health. Over to the chairpersons to take over the session 2.
Thank you, Dr.
And
Meena.
introduce the speakers.
Yeah. Dr. Meena, can we have the next speaker first? Has Tanveer joined?
I saw Tanveer's name.
Yeah, Dr.
Tanveer,
Tanveer
are
is
you
very much
available
there.
Yeah.
She was there.
So you can introduce Dr. Tanveer.
One sec. Has she logged out? Is there some... Dr. Tanveer, are you there?
Dr. Tanveer, are you there?
Ma'am, actually, Tanveer told me that she might get a little late in joining and we could shift
Then you
her
take the next
lecture
speaker. No
after
problem. No problem.
I informed Dr. Meena.
Yeah.
But I saw Tanveer's name logged in.
Okay.
He was
So
there.
our next
I think you go ahead to Professor Pandey, and then we'll come back to Tanveer as soon as she joins.
right.
It's better. So,
So-
please, Person Karishma, you introduce, or Rajesh, madam. Anybody can introduce. Karishma there?
Sorry, ma'am. Yes, ma'am.
You are
I'm
there?
Dr.
Oh, so you
Anil Pandey.
introduce, okay, you introduce Professor Dr. Anil Pandey.
Yes. So our next speaker is Professor Dr. Anil Pandey. Sir is an adjunct professor of neurosurgery at Apollo Hospitals, and he's a senior consultant neurosurgeon. And sir, I welcome you. Please, you can share your slides now.
Am I audible?
Yes,
Yes, sir. Yes, sir. Slides are seen.
Audible
Need to
and
change to the slide share mode, sir.
Yeah, I'll do that. Now, is it seen now?
Yes,
Well,
yes. Yes, ma'am. Yes, sir.
So thank you very much for inviting me to this academic session. And it was nice to be part of a different specialty, because we neurosurgeons are locked up in the head and the spine of patients. And so thank you very much especially to Dr. Meera Raghavan, whom I work closely with at Apollo's Hospital, Chennai. We neurosurgeons, like the famous Dr. Vertosik, are often baffled. We are tackled and sometimes defeated by our greatest adversary, pain. The neuraxis is the reason why we hurt. It protects but causes the most acute despair like no other experience of human. Like Dr. Menon said, we have these complex pathways starting from the nociceptors, then the pain pathways, then the intervening reticular activating system, the hypothalamus, the thalamus, the parietal cortex, the association areas, the frontal lobe, the neurotransmitter milieu, which differs for each patient. Pain as a God's megaphone is a terrible instrument. It gets our attention and warns us of danger. For us, the neurosurgeons, it is not that the frontal lobe, the pituitary, hypothalamus, adrenal axis, which is the main focus, but the huge burden of cranial and spinal pain is very, very important. Most of the pain syndromes which we neurosurgeons meet either is a neurovascular conflict of the cranial nerves, like the trigeminal neuralgia, which is very, very severe, but the biggest BUMOC or the largest volume is of complex spine deformities, whether it is the neck or the low back pain. Now, my mentor was Professor B. Ramamurthy, the father of neuroscience in India, and he used to call this the KKK syndrome, the Kai-Kal Kodachal syndrome, where we used to see a woman, coming with chronic back pain, and the MRI and the X-rays are all negative. And then he used to say that be very careful, avoid a psychosomatic or a functional etiology, and he used to call it a last dustbin diagnosis because it may allow for a disastrous missing of a real treatable cause. After all, after everything has been excluded, that means after all have been excluded, it is all in the head perhaps. So now the chronic pelvic pain, lumbosacral radiculopathies, intervertebral disc pathology, compression fractures, spinal stenosis, facet syndrome, primary sacral dysfunction, sacroiliitis, trochanteric bursitis are a long list of conditions which can coexist in patients or lead to complex chronic pelvic syndrome. Now, a 31-year-old hypothyroid lady was admitted with low back pain, bilateral sciatic pain, along with the perineal paresthesia, 45 duration. She kept on complaining of that sciatic pain, but her MRI of the lumbosacral spine and plexuses was normal. Her neurophysiological examination revealed a 4-5 radiculopathy, and she gave a history of abortion and weight gain of 10 kgs over a period of a year. She was initially suspected to have a UTI, and later she was referred to us. Another lady, again 35, obese, presenting with a 3-year history of low back pain, left-sided sciatic pain, this time associated with a stabbing, paresthesia, and burning sensation in the periurethral area. She was diagnosed with a urinary tract infection and referred to a urologist who suspected a ureteric stone and associated urethral spasm. Cystoscopy was performed and a urethral stricture was identified. Urethroplasty was done 1 month before presentation, but the pain persisted. The patient had no focal motor sensory deficit. Pace and Nagel's and Lessig sign, Freeburg sign, and Solheim sign were positive. Her magnetic resonance imaging was normal. Another lady, again with a similar history, again sciatic pain, and again MRI being normal. Again, the patient being referred to multiple specialists, the gynecologist, the urologist, and even the psychiatrist. Now, piriformis syndrome is an entrapment neuropathy. Now, this is a recent publication which has just come out from Springer, from neurosurgeons, and it has a chapter on the piriformis. It is caused by the compression of the sciatic nerve by the piriformis muscle. The piriformis pain is described as deep, aching type with tingling and numbness radiating from the gluteal and the perineal area down to the lower limb. Rarely, this non-disc sciatica is present with associated pudendal neuralgia due to an additional pudendal nerve type 1 entrapment. So 1928, it's quite some time back, he reported the first case of sciatic pain which could be attributed to the piriformis muscle. In 1934, our neurosurgical disc operations perhaps started in one way where this was considered to be the main cause of the pain in the low back and having sciatica as a major component. 1947, again quite early, Robinson coined the term piriformis syndrome for patients presenting with pain at the sacroiliac joint, greater sciatic notch piriformis muscle that is radiating in nature and causes difficulty in walking. Piriformis syndrome and non-disc sciatica. So now please see, all these patients would not have a disc on an MRI or any significant pathology. Remained till recently a controversial clinical syndrome with claims that it was being overdiagnosed and many others emphasizing its elusive and delayed diagnosis. This is a well-defined entrapment neuropathy, and the prevalence is nearly 6 to 17% of patients with back pain, which is a very large burden of disease indeed. And as you can see, it forms nearly 67, whereas the rest of them, including the sciatic tumor or the disc, all these other lesions are much less in incidence. Now, this is just a representation for the younger people in the audience that this is the piriformis, and you can see how the nerve can get trapped under a bulky or an inflamed thing. Please also note that the pudendal nerve is quite close, and the pudendal nerve can get entrapped, especially in a type 1 entrapment. So I will not repeat this to bore you because this is generally, again, gluteal pain, sciatic pain, paresthesias in the inguinal, lumbar, perineal, deep pain in the buttocks, hip, and posterior part of the thigh, calf, feet, and the rectum. Now again, see so much of an overlap between a chronic pelvic pain syndrome. Again, women show a higher susceptibility to the piriformis than men due to the wider quadriceps femoris angle in the ox coxae due to the hormone changes during pregnancy, where the muscles around the pelvis include the up to stabilize the area for birth. Radiating sciatica is a result of the neuromuscular conflict due to the close proximity of the piriformis muscle. The dermatomes, how clinically, when you see some pain, radiation to all toes is seen in the medial toes, and S1, the lateral tone, is seen in disc sciatica. Now, these are the various signs which you have to practice, and it is not for only the neurosurgeons or the neurologists, but also for the gynecologists. So because a majority of these patients land up with you because the MRI, even if it is done, is normal. And MR resonance neurography, very precisely, this is a 3 Tesla MRI done by Dr. Aditan at Apollo Proton. He's a colleague of mine, a radiologist colleague. And as you can see, the piriformis muscle is seen, the long arrow is seen coursing through the greater sciatic foramen side in this magnetic resonance imaging with sciatic nerve and pudendal vessels also very, very well visualized in this 3 Tesla MRI. Now, this non-disc sciatica can be complicated by this involvement of the pudendal nerve, and this pudendal neuralgia component is very, very possible, although it is not so common. But I was sort of very fortunate to have these consecutive cases where these 3 young women had this type of entrapment, and this was seen over a few years. It was not that. And because we are operating regularly on MRI positive lumbar discs, this forms actually a very small percentage of our practice. But that I feel is a referral bias, because the actual disease burden in the society is much more significant, and this should be well known by the urologist. That's why it was such a pleasure to present this rare syndrome to the gynecological audience. Now this, as I am again repeating, you can see the pudendal nerve, and you can see that this will cause allodynia, paresthesia, and pain in the perineal and the perianal area, and it can totally mislead the clinician, because the MRI is then you have to apply these Nantes diagnostic criteria, which is quite a long and elaborate table, and I will leave it to you to read it at leisure to improve your practice to see, are we missing this rare syndrome in this young lady? The mainstay treatment continues to be conservative. It continues to be conservative because, see, the entire thing is very deep. It is there. And the initial conservative therapy includes physiotherapy, manipulative treatments, physical therapy in combination with pharmacotherapeutic options, anti-inflammatory drugs, analgesics, muscle relaxant. But the lessons learned by us neurosurgeons from treating trigeminal neuralgia and from teaching these other complex pain syndromes, where the pain syndrome becomes something close to an epileptic syndrome, it becomes a channelopathy, it becomes a problem of multiple neural networks. And in these patients, you have these drugs like carbamazepine, baclofen, gabapentin, pregabalin, and also rarely antidepressants, which can really modify and improve the outcome of the patient. Now, chronic pain syndrome involves central sensitization, as Dr. Menon very well brought out in his place, and has a significant psychological component. And in fact, earlier on in early part of neurosurgery, as Dr. Vertosik points out, they literally used to target the frontal lobe, or they target the pituitary for patients with this significant pain, which was unrelenting and untreatable. Nerve blocks, once you have a precise localization on three things, as Dr. Menon would emphasize, probably these can be both diagnostic and therapeutic, where we can see the inflammation and involvement due to entrapment or due to a lesion of these nerves specifically. This was not possible earlier. We were not able to visualize individual nerves, and this has become a game changer, and it's been there for nearly 10 years now, where you can use this magnetic resonance neurography guided nerve blocks for the diagnosis and treatment of chronic pelvic pain syndrome. And so, in my concluding slide, I would like to re-emphasize that the piriformis and with its associated pudendal neuralgia is a very underdiagnosed condition. Please do bring it to your attention when you are assessing chronic pelvic pain. Patients with the pelvic piriformis syndrome have a long-term chronic pelvic pain. The diagnosis and treatment is a teamwork and collaboration. And as my first slide says, more than half the treatment is the awareness and knowledge of the condition. Thank you.
Thank you, sir, for this very enlightening talk. And this is a very new topic for all of us. So it was extremely intriguing to know that a syndrome like this exists. Thank you so much, sir. Anybody who has any questions
Thank
can
you.
put in the chat box, and sir will answer them later.
We can take later on, Karishma. We have to finish, okay?
That's what I said, ma'am. They'll put it in the chat box.
Okay, okay.
If Dheera is there, Dheera, you can introduce the next speaker.
Thank you. Okay, so we go ahead with Dr. Deepti Guduru. It's my joy to introduce her. I had recently met her at a conference and we had a wonderful exchange. So Dr. Deepti Goduru is a physical therapist. She's certified in women's health and pelvic floor therapy. She's completed her education at Ramchandra Medical College and the MGH Institute of Health Science in Boston. She also has the certification as from the American Institute as an American physical therapist. Currently, she works. She's been a clinical instructor at Hyderabad at NIMS as well as KIMS, and her interests are pelvic floor stimulation and the biofeedback, pelvic pain, urinary incontinence, functional bowel disorders, also with pelvic organ prolapse, obstetric and gynecological physical therapy. Over to you, Dr. Deepti Goduru, and you can begin your talk on pelvic floor rehabilitation.
Thank you, Dr. Dheera, for that very kind introduction. I hope everybody can see me and hear me.
Yes, we can see you and hear you, Dr. Deepti.
So it's amazing to always be a part of this group because I finally feel people understand what I'm talking about because, pelvic pain is not a very easy topic. And, physical therapists, we are used to dealing with pain, but, pelvic pain is a whole nother ball game. So just to keep this a little more focused, I'm trying to get my screen going. I don't know if it's up and running.
No, we're not able to see your screen yet.
Hold on. Let me just give this a try. I'm so sorry. Is it
We
visible
can
now?
see your screen.
Yes.
Yes. Need to make it in slide share.
Yes, better?
Yes,
Yes.
Thank you. I'll keep it short and different this time because usually we're talking about when it comes to pelvic floor dysfunction, we talk about either urinary symptoms or bowel symptoms or gynecological symptoms. Today, I'm going to focus just on pain. And like most of the eminent speakers ahead of me who spoke about different versions of pain, I'm going to talk in the perspective of a physical therapist when a patient is sent to me either by the urogynecologist or the colorectal surgeon or by the gynecologist when they present to us with musculoskeletal pain. And as a therapist, the dysfunction could be anything. It could be incontinence, pain with incontinence, or storage issues, sensory issues, urgencies, or voiding difficulties, recurrent UTIs, or a prolapse. All of this can contribute to the pelvic floor dysfunction and bowel symptoms. But today's presentation will be focused mostly on just pain and pain rehabilitation in a physical therapy clinic. So one of the biggest issues that a physical therapist faces is the fascia. Actually, so fascia is the bread and butter of our musculoskeletal work. It's the most pervasive tissue in the body. The muscles are all surrounded by it. So are the organs, and you have to imagine fascia as a three-dimensional organ. It's not just like flat. It's all encompassing. So I think the surgeons are more familiar with it when you go inside and take a look at, the tissues. But the deeper the fascia is, the thicker it gets. That's one very important point for a physical therapist. And also it's highly innervated and very poorly vascularized. So hence the pain perception is higher, but when there is tissue breakage, the healing is lower. So that's when the vascularity and the innervation come into play. So, and also a very important thing, like muscles, for a therapist or anybody who's working with exercise, we have principles of load, how a muscle responds to loading or repetitions. Fascia responds the exact same way. So this is a picture which is very important. When you think about fascia, it is not isolated. We always think about it as an interconnected cross fibers which are encompassing the whole body. So think about it like a sweater you wear all over the body, but when you're pulling at one string, the other part gives away. So the bones are keeping you up. The muscles are running across the body, but the fascia is interconnected. So when the muscles contract, the fascia contracts. And that's what gives you the tensegrity. That's the word we like to use, is the solid structures, which are the bones and the muscles, are the ones which are giving the tensegrity, but it's the facial movement which keeps them in place. And the next one. So I'm moving directly into physiotherapy intervention when you're coming to musculoskeletal pain. And so we're lucky enough, and I am lucky enough, that I get to work with a lot of great physicians and surgeons where most of the organic causes are already ruled out. So by the time they come to me, I am dealing mostly with myofascial pain only. So this, ideally, we would like to see them before any surgical intervention or before any chronic medical prescription, is because then we know whether myofascial treatments are working on the patient. So we have a good rapport with our consultants, where we are referring them back when we think the myofascial work is not working. We refer them back to see if there are any more organic causes for it. But one of the most important factors is, Dr. Amita was talking very eloquently about a lot of history taking. So we do a lot of extensive history taking to know what increases the pain, what decreases the pain. And the first and foremost thing we dig into is a lot of education, the biopsychosocial model of it, and also self-care. Before we get started, we go through the entire triggering factors and we try to negate most of them as much as we can, which contribute on a daily basis. So these are the common trigger points when it comes specifically to the to the pelvic floor. You can see the anterior levator ani, the inferior portion of it, middle portion of it, and superior. So we dig in quite deep, almost, I would say, about 3 centimeters deep we can go in if the patient allows, and pain allows also. You have pains at the coccygeus, you have them at the sphincter, you have them close to the prostate area, the obturator on the sides, and the coccyx area all the way to the bottom. And not to forget, myofascial pains are very different from the sensory pain. So we always, in our history, we do a myotome dermatome check. So we look for sensitivity if it's more of a sensory pain versus a myofascial pain. So we tend to map it out also before the treatment starts, because we do try to do electrical stimulation. So we keep in mind if the patient has hypersensitivity of any sort. This is the difference when, I know it's a very scary looking slide now that I look at it, but the one which shows the pelvic floor is the common myofascial trigger points you would think when you think about an interstitial cystitis or a tight pelvic floor only. So this is a local pelvic floor which can refer pain at the groin, at the buttocks, bilateral trochanters at the hip. It can be right at the perineal body, very localized. But once it's a myofascial, typical myofascial pain, it can spread quite a lot. It is very diffuse. The more chronic it gets, the more diffuse it gets. So it can go throughout the gluteal and hamstring length. It can go throughout the upper multifidus. So it stretches as the imbalance is increasing. So the more the body is off of balance, the muscles get tighter and tighter, and the fascia starts going into knots. So the pain is more diffuse. Sir before me was talking about piriformis syndrome, and he was mentioning how the pudendal nerve is right next to the the sciatic nerve. So we tend to focus so much on the piriformis, but we forget there's the gluteus medius above it, there's the gluteus minimus, there's a quadratus, there is so many other muscles which also have to be stretched out when we realize that this is what is causing the pain. So it's multi-layered, so we go in muscle after muscle after muscle. So these are some of the modalities we commonly use in our clinics. Definitely ice if the patient can tolerate and doesn't have any hypersensitivity. Heat, again, this is up for debate. People like heat, people like ice. Pain is very different in different people. So we always check sensitivity before we prescribe physical modalities. Ultrasound for short durations, 7 to 14 days, does help a lot, therapeutic ultrasound. And we do use a lot of electrical stimulation. When the patient is having a very tight pelvic floor, I would not recommend increased stimulation, but we have relaxation settings also, where it is more of a shorter contraction and longer relaxation. that helps relaxing the pelvic floor. We do use TENS a lot, which is the transcutaneous electrical nerve stimulation. There's the slide over there, which is showing the placement right about S2, S3 is where we put the electrodes. And the frequency modulated electrical neurostimulation, not very common because it requires a lot more time, compliance is lower. And the last one, which says over there, spray and stretch. It's a very funny way to say it. It's nothing but if you can identify the trigger points, you can identify the taut bands, you stretch them specifically, and you spray the analgesic sprays or a cream, and it actually helps really well. But you have to identify the trigger bands first. And this slide was shown earlier also about how important posture is, because an anterior pelvic tilt causes all the dysfunction you want. It shortens everything in the front, which includes the pelvic floor, weakens and increases the lordosis on the backside. So getting ergonomics right, getting day-to-day activities, getting your exercise routine, and getting your posture right is very, very important in any kind of pelvic floor pain. And this, like the previous slide, we were also talking about biofeedback. Biofeedback primarily in pain is not what we use initially. If there is a dysfunction, like avoiding dysfunction, or if we see a non-functioning pelvic floor, to get the muscles activated is when we use it. But since a lot of people have curiosity about biofeedback, I put it out there. So after 5-6 sessions where the pain is lesser, and we're talking about activating the pelvic floor, biofeedback. The one on top is an electrical biofeedback, and the one on bottom is a pressure biofeedback. And the one which shows the computer screen is you can project most of these biofeedback machines. You can put them on a bigger screen. They come with apps now. So you can encourage your patient to use their own pelvic floor muscles once they're pain-free. Or in retrospect, you could use the abdominal muscles if the patient is dysynergic, or the patient is using abdominal muscles more, pelvic floor muscles less, and vice versa. You can put the electrodes accordingly and encourage the muscle movement you want. And that's how biofeedback setup looks. And one of the most important things with biofeedback, why it tends to not be very successful, is if the therapist or the clinician who's doing it changes, because the instruction has to be consistent and the patient has to put voluntary effort. That's all there is to it. There is no big secret to how biofeedback is performed, but consistency is key. And one of the most important thing, this slide should have been earlier, is relaxation and diaphragmatic breathing in pelvic pain. That's because most of the times when the pelvic floor is so tight, it does not function. So that, because the pelvic floor is connected to the abdominal wall, which in turn is connected to the dome of the diaphragm. So they also tend to be dysynergic. So the diaphragm actually, instead of going upwards, goes downwards every single time. So when we teach breathing, we have to actually teach a good diaphragmatic breathing, where the dome of the diaphragm goes up and down, and you can see the thoracic expansion really, really well. That way you can presume safely that the pelvic floor is also moving. And sometimes we find adhesions in the diaphragm. Sometimes we find adhesions in the abdominal wall. The woman might have a cesarean section. So we check for the breathing pattern. If we find restrictions of any sort, we first release them, and then we ask them to comply with breathing. Therapeutic exercise. So the importance of exercise: once pain is taken care of, you strengthen the weak muscle, and aerobic exercise is also very important. Voluntary contractions. Madam was telling Kegels is not the greatest idea for a person with pelvic pain, but if the trigger points are released, we start encouraging gentle, very gentle isometric contractions because every isometric contraction is followed by a relaxation. So they have to learn to contract before they can relax. And this is the biggest arsenal we have, which is called the soft tissue mobilization. If I was back home, I would have shown some videos. Next time, maybe I can have a couple of my patients demonstrate how we do mobilization. We get deep into the trigger points. We do it with a variety of tools. I'm going to show you a couple of tools which we use right about there. So one of it is called the pelvic wand. So these are all just for myofascial pain. So it depends if it is a localized pain, it's a local trigger point which is going deep in the pelvic wand, or ischemic pressure with your finger works very, very well. But then once the pain is released, we actually use dilators also gently. We give them a protocol about that is a good way to stretch your pelvic floor if the patient is tolerating it. And right below the dilators, you can see our cupping. So the gentle cupping we do is actually very, very, very helpful for the patient because it increases vascularity and releases the stress in the muscle. And on the bottom, you can see the gentleman who's doing pill rolling. We couldn't show you, I don't have any pictures of the pelvic floor pill rolling, so I'm showing the pill rolling of the back muscles, but that's how we release taut bands. Trigger points are different from taut bands, so gentle pill rolling releases taut bands. And there was one slide I wanted to go over. So this is, we do a lot of dry needling in the clinic. Dry needling is safe. It can, people know it as acupuncture. The difference is dry needling is more medical based. So we don't have a different system. It's the same muscle, same fascia. We try to palpate the deep trigger point with the needle. 3-4 sessions of a needle can produce wonderful results. Patient initially is a little apprehensive, but once the needle goes in, they're fine. Hair thin needles, and it gives beautiful results. But there is another way. If the patient has more pain and the pain is more central in origin, not just local, you could use the same TENS or electrical stimulation we use for the needles, and that is what the model here is showing. I personally haven't used it after college because we just don't have the setup for it here, but it is quite commonly used abroad, the electrical stimulation, needle stimulation. And the next slide here shows all the manipulation which we do is single muscle by muscle. So we go superficial layer, intermediate layer, and the deep layer. So we make sure that we cover first with the pad of our finger, then it could be the pelvic wand, could be the dilator. We make sure the pelvic floor is completely released. Just think of it as a neck muscle or a back muscle. So we find tension in it and we release it. And the only thing is when we do a very strong myofascial release, and it has to be strong because we get into the deeper layers, sometimes you could be sore for 3 or 4 days. Like the initial pain goes away, but the muscles around it might be sore. We do warn you about it. You could see a little bit of bruising because we do break into the facial layers, and you can see a little bit of bleeding. And sometimes people do complain of fatigue, dizziness, or headache because, all of a sudden there's a change in your hemodynamic balance and they get up and they feel a little woozy. Just ask them to sit for a little bit and, give them some water and they're usually fine. I rushed through most of my slides, so thank you for that, and I'll be happy to take any questions.
Thank you, Dr. Deepthi. That was a very comprehensive talk, yet very informative. I think it's well recognized that pelvic floor rehabilitation forms a very central component in management of pelvic pain. We can move on. Yes, if there are any questions, we can have them in the chat box and we can discuss them at the end. Moving on to the next session, is Dr. Rajesh Kumari ma'am there to introduce the next speaker. Dr. Karishma, would you want to go ahead?
Sure. So can we have Tanveer's CV, please? So with a lot of pleasure, I would like to invite Dr. Tanveer, who is a very eminent gynecologist and laparoscopic surgeon. Tanveer will be speaking on pudendal and neuralgia. Tanveer, please go ahead.
Thank you so
Want
much.
me to share your slides, Tanveer, or will you do it?
Well, I think I should be okay. If I'm not, then I will take your help. Maybe I'll keep my video off if that's okay. So let's see if this works. It's fine, or else I'll just. Okay. Can you see my slides? No or yes?
Yes. Please put them on slideshow.
Yeah. I'm sorry. Yes. All right. So 1 second. I'm so sorry. I'm just going to. I can see Deepti's slides for some reason.
Yours was shared before.
Okay. Yeah. So, a very good evening. And today I'm going to talk about pelvic neuralgia. So, without wasting much time, I was supposed to speak first, but I'm very happy that Dr. Anil and Dr. Deepthi have covered, the other part of it. So, it's easier to understand. So, let's go back to the basics.
Our slides are not visible now, Tanveer.
Now?
No,
Are
now,
they?
yeah.
Are they visible?
No.
No, not yet, Tanveer.
Okay, I'm sorry. Is it visible now?
Yes.
Yes, yes, now it's visible.
All right, so I have no financial disclosures, and my topic today is pelvic neuralgia. So, as we understand, the female pelvic innervation is divided into somatic and visceral, and the definition of pelvic neuralgia. So, I'm not going to get into the definition of chronic pelvic pain again. I'm sure it's all covered. So, it is the pain in the nerve pathway, which is severe shooting pain that occurs due to a damaged or irritated nerve. And sometimes there is a micro injury, a repetitive micro injury. So, pelvic nerve anatomy, main nerves that constitute the pelvic nerve anatomy is the pudendal nerve, that is the main nerve. So, many a times when we talk about pelvic neuralgia, it's more or less saying pudendal neuralgia. It is the main nerve of the perineum. The next is the ilioinguinal nerve, which is lower abdomen and groin. The genitofemoral nerve, the genital and the inner thigh innervation, obturator nerve, which is the medial thigh and the hip abduction, sympathetic and parasympathetic pathways. Iliohypogastric or ilioinguinal nerve is L1. It mainly supplies the skin, the musculature of mons pubis, transverse abdominis, and the inferior oblique. So there is a sharp pain which refers to the suprapubic area, the labia, and the thigh. And this very much happens after cesarean sections. When you give a fan and steel, almost 7% of the times, and laparoscopy, depending on the port placement, and hernia repairs. So it's very important to counsel your women or patients, especially after laparoscopic surgeries, also that sometimes this pain can go on for a long time. So it can last for 6 months, 3 months, or even longer than that. Sometimes I think even up to 2 years. So a little bit of counseling, if they come back with that kind of, paresthesia, that's what you do. Or you give pain reliefs with local blocks. The obturator nerve, which is L2, L3, and L4, it has an anterior and a posterior division. It supplies the obturator internus, the adductor muscles, hip joint, and the medial thigh. Usually, you see these injuries during after a TOT, that is the transobturator drapes, and it's mainly the groin pain which women complain of, almost 12 to 16%. That means if you go too lateral, as you find in the diagram itself, if your TOT is too lateral, and that's why they say hug the bone, be very close to the bone. If you go too lateral, that can get injured. And also during endometriosis excision, that so much is happening now, paravaginal defect repairs, and pelvic node dissections. The sacral nerves are S1 to S4. Mainly, these injuries happen during bilateral uterosacral ligament suspensions.
Tanveer, can you increase the volume because your sound is.
Oh, so sorry. Can you hear me now? Am I better?
Yeah, now better.
Okay. So the types of pelvic neuralgia are pudendal, ilioinguinal, genitofemoral, obturator, and mixed presentations. The pudendal nerve pathway, the origin is from the sacral plexus, that is S2 to S4, and the course is through the greater sciatic foramen, which goes around, as you find in this diagram. You just try to follow the diagram, the greater sciatic foramen, and around the sacrospinous ligament. You can see the white structure there, the sacrospinous ligament, which is marked, and it enters the pelvis through the lesser sciatic foramen right there, and travels through the Alcock's canal down under. So the branches are inferior rectal, perineal, and dorsal genital. So whenever you have the pudendal nerve injury or neuralgia, it is the anal pain, the perineal pain, and the genital pain usually that most of the women complain, and especially when they're sitting. The pudendal nerve neuralgia is most common form of chronic pain, almost 1 to 4%. It's also called the Alcock's canal pain and a cyclist syndrome. So it occurs mainly in women almost about 6 times more common compared to men, and the peak age is 50 to 70 years, and very common in the cyclist. It's because of cycling and prolonged sitting, also because of childbirth trauma, hernia repair, and some gynecological procedures like I've mentioned before. So the pathophysiology is either nerve compression or entrapment, or because of stretching, and this can occur while there is a strain when you're constipated. You see a lot of women coming with constipation. I think it's like Sir was talking about, it's very underdiagnosed. We don't pay much attention to it, but there are women who have very severe constipation, and then when it's not corrected at the right time, they have a micro injury which is repetitive, and that's when the problem happens. Then there is central sensitization and also childbirth. I haven't seen too many, but I remember one woman who had terrible pain which went on for 2 years, and then we tried to give her everything, and that time we really didn't understand why she had this pain. But then on retrospectively, when I think about it now that I'm part of FEPA and I'm learning more and more each day, when I think about it, it was just because of the stretch at the level of possibly ischial spines or lower down at the sciatic foramens, and that's where she complained of terrible pain while sitting for a long time. And there's inflammation, irritation, could be ischemia, nerve damage, central sensitization, muscle spasm, guarding, and sometimes referred pains. The presenting symptoms are sharp burning, shooting pain, there's numbness and tingling, sitting intolerance, it's a hallmark, and they feel relieved while standing. They also have sexual dysfunction. They have pain either during intercourse or after, many a times, and toilet seat sign relief. So that means, when they're actually defecating or passing urine, they feel relieved. I guess it's because possibly of the position that they are in, and the muscles just stretch and kind of gives them the relief. Usually it's unilateral, and hyperalgesia is present. Also another thing is the Valkix phenomenon. It's a sign. So in this particular sign, when you examine these women, you put pressure at the level of the Alcox canal. You give the little pressure with your hand. I think Deepthi showed beautifully some of the I was thinking one of the pictures she had where your hand is inside and you're pressing on, near one of the muscles, and you press right there, near the Alcox canal, and that's where the woman complains of pain, a lot of pain, and sometimes even rectal pain and perineal pain. So the associated symptoms are bladder, urgency, frequency, bowel is constipation, pain with defecation, dyspareunia, there's a sleep disturbance, anxiety and depression, and functional disability. So the quality of life is definitely affected. So the hallmark of diagnosis is clinical history and physical examination. So the main is the history, because pudendal neuralgia or pelvic neuralgia is also a diagnosis of exclusion. Pelvic floor assessments, nerve conduction studies, electromyography. There's also MRI imaging, and there are types. So I did not define it here because I thought it'll be a little elaborate, and I didn't want to, a little more time for it. And they're also diagnostic nerve blocks. So when you give a pudendal nerve block and the woman gets better, so most probably it could be because of the pudendal neuralgia. Now, the Nanton's diagnostic criteria is one of the most important diagnostic criteria, and all of them have to be positive. That is pain in the anatomical distribution of pudendal nerve, pain aggravated by sitting, not awakened by pain at night, no objective sensory loss on clinical.
Tanveer, you're not audible.
I think she had lost her network.
Tanveer, you're not audible. Tanveer.
No, I think she had lost her network.
Yeah, I think even the
I
car.
think Tanveer is traveling, so she's losing the network in between,
Yes,
and that is the reason the voice is also not that clear.
Maybe, madam.
She's traveling while giving talk.
Okay. Tanveer, in fact. Hello, namaste, madam.
Namaste, how are you?
Namaste, madam. Fine. So what can we do? Should we wait or should we move to another session?
I don't know.
Sarita, madam, what do you say? Should we move? I don't know.
I think, ma'am, we should move ahead because Tanveer is on
Okay.
the way to the airport in Chennai. So
Okay. So late. So Meena?
Yes, ma'am.
Yeah, so I think
So I request the chairpersons to give few words and close the session, the second session. Over to the chairpersons, Dr. Karishma, Dr. Deera, Dr. Rajesh Kumari, madam.
So I would like to thank all the three speakers for their wonderful talks, and all these three topics were very different and very unusual topics which are not discussed very often. So I think we'll be dealing with the questions in the end of the session. But for the time being, thank you to all the speakers for their wonderful lectures. Dheera can add something if she wants to.
Yes, once again, thank you, Dr. Professor Dr. Anil Pandey, Dr. Deepthi, and Dr. Tanveer. I think the second session was a reminder that chronic pelvic pain requires a multidisciplinary approach, and coming together, working as a team, we can give better solutions to our patients. Thank you once again.
Thank you. Dr. Meena, we can proceed with the next session.
So now we move on to the interesting panel discussion. Now I request Dr. Kavita Banwal ma'am and Vidya ma'am to take over the session. Now request Nilima to project the CVs. Dr. Nilima? So we have chairpersons for this session, Dr. Mandeep Pal sir, who is the principal of Kalyani, West Bengal. He is the recipient of IMA Doctors Day Award 2023, IMA Headquarters, New Delhi. He is the ICOG Visiting Professor 2023, Dean, Indian Academy of Obstetrics and Gynecology 2023 to 26. Next slide, please. Nilima. And we have Professor Anil Shakare sir, who is the ex-associate professor, Department of OB-GYN at Nanded. Worked as assistant professor at GMC Nanded for 11 years. Undergraduate and postgraduate teacher and examiner. Operating faculty of live surgical workshops at various national and international conferences. He has got 23 scientific publications in various national and international journals. Among us, very few Indians who have contributed to Williams' textbook of obstetrics and served to African countries and operated hundreds of cases there. And we have our moderators, Dr. Kavita Banwal ma'am and Dr. Vidya ma'am. As we have introduced Dr. Kavita ma'am already, take privilege in introducing Dr. Vidya ma'am. Next slide, please. Dr. Vidya ma'am, she is the director, Touch of Joy Women's Clinic and Fertility Center, Nanavati Max SSH. Over to the moderators to introduce the panelists. Kavita ma'am, shall I introduce or you will be
Can
introducing
you
the
put the
panelists?
slides on? Can you share the slides?
Nilima?
So first and
Slides of the
foremost,
panelists.
yeah, I want to thank all the speakers. I think they've done a great job in the theoretical understanding of chronic pelvic pain from the gynec perspective, then the bladder centric, then the understanding of the pain pathway, the physiological, the physiotherapist helping us in the multidisciplinary, the neurophysiology, which Dr. Anil helped us in understanding with piriformis. So all this has been a very theoretical, and now let us culminate with a practical understanding so that we all can have good take-home message from the experts that we are going to have in the panel now. Can we have the slides, Dr. Meena?
Yes, Nilima, can you
Yes,
project the CV of the panelist?
Yes, Gauri,
Dr. Kavita
please
is
share
there?
the.
Yeah. Madam, will you introduce?
Yeah.
Yes, yes.
Yeah.
So,
Thank
Kavita
you.
ma'am, shall I introduce?
Yeah. Yeah, Dr. Meena Malingam is master trainer, UMC professor in.
Ma'am, already introduced, ma'am. No problem.
Okay. And she is co-chairperson Urogana Committee, OGSSI, and she is also member Urogana Committee, FOXY, and she is very good debater and very good, I think, coordinator also. So next slide. She practices urogynecology. Next slide.
Nilima, next slide.
Yeah. So
Nilima.
Dr. Monica Gupta is professor in BMMC, Safdarjung Hospital, New Delhi, fellow in urogynecology and pelvic reconstructive surgery from UK. She has a special interest in urogynecology, critical care obstetrics, chairperson, urogynec committee. So next, please. Next slide. Dr. Latika Chawla. She is consultant gynecologist and endoscopic surgeon, endometriosis excision surgeon in Mumbai, fellowship in advanced minimal access surgery under Dr. Rakesh Sinha. Next slide. Dr. Pragya is a very good friend of mine. She is from Patna and she's IVF specialist at MGM Hospital Research Center, and she chairperson genetic fetal medicine in 2016. She was in from Proxy, and she has Patna Gynae Society and different platform. She is founder secretary of Bihar chapter of ISAR. Next slide. Dr. Neera Thakre, madam, was chairperson Urogynec Committee Foxine between 2017 and 19, and she is honorary secretary UOGS. I think she has served an ex-assistant professor, IKDRC Keshar SL Medical College, Ahmedabad. Welcome, madam. Next. A special interest in urogynecology. Professor J.B. Sharma sir was chairperson urogynec committee between 21-24, just before me, and he has been awarded Dr. Vishera Award by Honorable President of India for research in obstetric gynecology, more than 425 publications, and author of many books. So welcome, sir. Next. Dr. Dipti Gudru, I think she has already been introduced. We just heard her talk. So let's start the session. Anybody else? Dr. Meena, I think we have completed. So should I share the screen?
Ma'am.
So
yes, ma'am.
Yeah, let me share. Hope I can do. So is it visible? Let me.
Yes, ma'am. Yes, ma'am. Visible, ma'am.
Okay. But not moving, right? I don't know.
No, it's not moving.
Let me slide control. I've done. I had tried and it was moving, but I don't know what happened. And it's not
Just click
showing
and
other
see,
links.
ma'am. Just click on the next button. The arrow.
I'm clicking it, but let me see.
Madam, you can close and reconnect, madam.
This has, I think this has been enlarged. Still is coming. Vidya, you have there?
Yeah, maybe from the central office, someone can. Dr. Vidya, can you
Yeah,
from
I'll
your
do
end?
that.
I have shared with Vidya also. I was sharing just now, but I don't know what happened. I think something happened.
Okay.
Kavita, ma'am, it is sharing. Just can try once more, ma'am.
Yeah, try once more. If you can't, then I'll share.
Yeah, I think you share, and there would be a kind of arrows at lowermost, and then click on those arrows.
Okay. Let me share.
First share.
All participants here. I'm just trying once. If not possible, then Vidya will share. Yeah, so I think.
Yeah,
now,
We are able to see your
it's
screen.
visible.
Now
Yeah.
just make it
Yes.
slideshow.
Oh, so now it's
Yeah,
good?
it's okay, ma'am.
Yes.
Yeah, okay. So I think this has already been discussed by Dr. Amita, Meera, everybody, and Dr. Anil Pandey. Everybody has discussed, but still, what is chronic pelvic pain? That is, American College of Obstetrician Gynecologist defines chronic pelvic pain as non-cyclical pain of at least 6 month duration, and that should last for at least 14 days in a month, and that appears in locations such as pelvis, interior abdominal wall, especially in the lower area, lower back or buttocks, and that is serious enough to cause disability only to the medical care. The International Association for the Study of Pain defines chronic pelvic pain as chronic or persistent pain perceived in structures related to the pelvis. It is often associated with negative cognitive, behavioral, sexual, and emotional consequences, as well as with the symptom suggestive of the lower urinary tract, sexual, bowel, pelvic floor, and gynecological dysfunction. So I think the scope of the problem is very high. 15 to 20% of the women aged 18 to 50 suffer from chronic pelvic pain, and it is notoriously challenging to manage and frustrating both for the clinician and for the woman. 40% have no definitive diagnosis after first evaluation. So it's an enigma because of overlapping conditions, highly heterogeneous presentation, and is multifactorial in etiology. It has biopsychological social complexity, and there is delay in diagnosis. So more than, I think, 4 to 5 years. So this is the problem. And now this is the case. Mrs. XS, 36-year-old software engineer with high profile job and married, one normal delivery, but forceps was applied 5 years back. She is anxious, irritable, and she always complains constant dull lower abdominal pain for last 4 years, which is worsening now. And also with the premenstrual period, there is dysmenorrhea on and off. Sometimes GI symptoms are also occurring, and there is a history of urgency and frequency for last 2 years, which occurs. Sometimes it vanishes, but mostly she had this problem. So Dr. Monica, has she joined? What history will you focus on and ask beyond what is given? Dr. Monica? Monica Gupta?
Yeah,
I think,
good evening.
Madam, go back to the previous slide.
Good
Let her
evening,
have
ma'am.
Yeah, this one?
Yeah, yeah, the one after this.
Good evening, ma'am. At the outset, I would like to thank all of you for having me at this August forum. As regarding the case, we have a 36-year-old female here with a almost, 4 years history, long history of dilated pain. So as you had described the definition of chronic pelvic pain, um, as such, she is fitting into the problem as per the duration of the pain she's been having. But having said that, we have already listened to some beautiful lectures, and we really know that this pain, is not a diagnosis. It's a symptom, and we really need to go to the realm of the pain, what it could be due to. So, so I would first
Dr.
like to
Monica,
focus.
yeah, would you like to ask
Like
her
to
about
focus on the pain per se. I would like
Yes.
to go into the details of the pain per se. How was, it was first experienced. It's okay. It has been chronic, fine. Its relationship with the period she's having, its variation in severity, if ever she has experienced any kind of triggering factors or relieving factors which she has experienced, any previous treatment for this pain if she had taken. And as she's having this dysmenorrhea thing, dysmenorrhea, what kind of dysmenorrhea? If it is, we can have an idea of maybe a uterine pathology, coexisting uterine pathology, or an endometrial pathology, just by a comprehensive history taking. And more so, I would not probably stop here. Maybe, she has giving some symptoms of urgency also. So since urinary symptoms are also associated, this association of pain with all kinds of involvement of, other organs in the pelvis will have to be taken care of, and a comprehensive history will definitely guide us to move in a particular direction, and not to forget the sexual history as well. If this pain gets aggravated, and is it affecting her sexual history? And one very comprehensive way to find this out would be use of validated questionnaires, as has already been discussed. Yeah.
Yeah, I think, Monica, you hit the nail right now, is validation of her pain, and to have questionnaires, and to have a pain score. So I think, Monica, when she's come, we have to understand that previously what all treatment she has taken. And in the first history only, we should be understanding that she's already come, she's looking anxious and irritable. That itself says that she's already become so vulnerable that to get a history from her is going to be difficult. So we will have to show her empathy. The first meeting has to show empathy, validate, and to make her realize that we are here to listen to her and understand what she's going through. Okay. Madam, can we go further?
Yeah. So I think she has covered these things, pain scores should be asked. So now onset initially severe dysmenorrhea, which would settle with antispasmodics. Now continue with dull pain, which worsens around the menses, sometime bloating, diarrhea cyclically, urgency frequency, which triggers with certain food and also with the coitus. And character of pain is deep, dull ache with the stabbing episodes and burning at times. Rest gives some relief, but the spicy food triggers, and so does the stressful work days. Intercourse worsens the pain, even full bladder, and when she passes urine, she feels some comfort. So there is some impact on the quality of life also. There is low productivity with work leaves, marital strains, depression, social distancing. So any other history you want to cover and how important it is to know her past treatment and outcomes. Dr. Neeta Thakre, madam. Neeta, madam.
Dr. Neeta, are you around?
Madam,
Yeah, I'm there. I'm there. So
madam,
from
yeah.
the history,
You
it
are
is very
breaking, Dr.
important
Neeta.
to know.
Hmm.
Just a minute. Am I now
Yes,
audible?
Yes, ma'am, you are.
Yeah. So from the history, we have to know whether the patient is having this complaint since how long, and whether the same complaint gradually increase in severity or not. Because whenever there is a patient having pain which is correlated or it is associated with menstruation, we have to find out whether this pain is related to uterus, means whether uterus, ovaries, or any other pelvic organ, or it is because of involvement of bladder. So to rule that out, we have to ask her whether how long she has been having this, whether there is any past history of any other such issue, and whether she was operated for any other problem that she had in the past. Because from the history, it is very clear, looks like that maybe she is having endometriosis, and that is the reason we need to go for the past history. And from that, we will know that, whether she has any history of, as urgency frequency is there. So past history of any recurrent urinary tract infection, that we have to find out.
So I think a complete in detail understanding of her history is very important. And I think we have covered up that part of it. Now let us go further, madam. Anybody else wants to add anything? Or we are okay with this slide?
Absolutely.
I think all points have been covered. Yes.
Okay.
Yeah, okay.
Dr. JB.
So looking at the menstrual and the past history, she gives, like Dr. Neeta wanted to know about her menstrual history. Now she's had a regular menstrual cycles, but with severe dysmenorrhea. She's not had any comorbid conditions, but yes, as you said correctly, that she has undergone a laparoscopic excision of the chocolate cyst with ediciolysis 2 years ago.
That's
She
a very
has given us
significant
history.
history, absolutely.
Yeah, this is a very clinical important point for us. And she also gives us history of recurrent UTI. Now, recurrent UTI with the symptoms of urgency and frequency are always labeled as UTI. But what we have seen here is she has been taking over-the-counter medications, which probably her first two doctors probably had given her, and she thought that was the only way to feel relieved. And she went on taking it over the counter, but there were no urine cultures ever done. When we probed into her history, she never told us anything about her cultures. She's given a history that she's met too many physicians who helped her, of course, because they always gave her some medications like antibiotics or probably some hormonal suppression medication, and she did get temporary relief. But only thing what she kept on saying is probably sometimes my urinary symptoms would keep coming, frequency, urgency, and all that. Now, all this pain has impacted, just like Dr. Menon said, that pain can impact not just the body, but also the mind and also the family and the society. So she definitely is experiencing a lot of mood swings, more of low mood, unable to cope up with the situation. So her coping mechanism has gone down. and she has no support from her partner as well as her family. So now you have a woman who's completely shattered because she has no support. Now let's go to the next slide, madam. Now, Dr. Latika, if you were her gynecologist and you are the first point that she came to you, how important it is for you to understand her pain score and the symptoms that she's been telling us, and what would you come, you would you collectively understand it and get into the larger scenario for her management?
First of all, thank you so much for having me, Dr. Burnwal, Dr. Vidya ma'am, and our entire FEPA team and all the speakers. If we can just go back to the previous slide, the reason I want to go here is to really state that this is exactly what is everything wrong with the women receiving care in chronic pelvic pain. That is the reason why, there is a delay of 2 to 5 years, as we saw in the first slide. Any woman who has severe dysmenorrhea is usually ignored. There are so many women who come in the adolescent age group who are told, oh, once you have a pregnancy, your pain will reduce. Once you have, your hormone HPO axis matures, your pain will reduce. There are a lot of overlapping factors like PCOS where they can have dysmenorrhea. So severe dysmenorrhea, first of all, should not be ignored or not just be given, pain relief medication and said that, we'll see at a later date. Secondly, laparoscopic excision of chocolate cyst with adhesiolysis is actually a huge pointer. Adhesions in endometriosis happen because of the endometriotic tissue, which creates scar tissue. So excision of this scar tissue and excision of these endometriotic spots
Latika,
and
you are breaking a
nodules is
little.
the complete treatment.
Latika, you are
Adhesiolysis is actually done with in a blunt manner. It actually incrementary. Sorry. Is it better now?
Yeah.
Yeah, better.
Am I audible?
Yeah.
Hello?
Yes.
Am I
Yeah.
audible now?
Go on.
Yes.
Yes.
Yes. So I was saying that adhesiolysis is incomplete treatment. Excision of endometriosis is what is required. Thirdly, as Dr. Vidya rightly pointed out, recurrent UTI over-the-counter medications is something which is very rampant, but we never reach to the diagnosis of whether there was actual urinary tract infection. So having said all of this and giving over-the-top suppression medications, it not only increases anxiety and depression in these patients who are not getting relief, but also lead to the point where, family and all of that also start questioning them that, oh, you have these symptoms and nothing is getting better. So this basically puts to the point where what can be done and, is it important to pain score? So yes, it is important to pain score. Pain scoring, there are of different modalities, the McGill questionnaire, you have the BPI, which basically help us understand not only the severity, but also the possible origin of pain. One of the more important things in pain scoring is actually from the prognostic point of view, especially in our OPDs. I use the VAS score, which is a very simple pain score, but it helps me understand if the management that I'm giving to my patient is helping or not. So I ask them to come back in 2 weeks, 4 weeks.
Basically, it helps you in a follow-up of understanding how the patient is doing with the
Absolutely.
treatment.
So prophylaxis, in the sense that how much it is helping or not, that is then. Of course, the larger scenario is that we are possibly dealing with more than just endometriosis. We are possibly dealing with a component of bladder. We are possibly dealing with a component of pelvic floor muscle spasm.
So there is a larger scenario than what actually looks like, right, Dr. Latika?
Absolutely, absolutely.
Okay.
Yes.
So, Dr. Pragya, would you like to add anything from your perspective? Anything more that Dr. Latika said?
At the outset, I would like to thank ICOG and also Urogynecology Chair, Dr. Kavita Barnawal, for this opportunity. Well, it's a privilege for me, being a governing council member also of ICOG, to be involved in this CME. Now, most of the things have been covered, but from infertility point of view, now if you look at this, I mean, she has a child who's about 5 years
Yeah.
old. So, as an infertility specialist, I would always like to ask her, or, she may
Absolutely.
just tell me that, she wants the second child, or has she presented with secondary subfertility. Because, pregnancy can be a solution to a lot of problems. And secondly, I would always like to ask her about if she has any vaginal discharge, because that has not been covered, so far. So any greenish or any yellowish, greenish, white discharge,
We must
because
rule
all
out
that could
vaginal
point,
infection.
it
Yeah.
could point
So
to
I think, Dr.
PID.
Pragya, you're right. We
Yeah.
have to understand her obstetric history and
Yeah.
her need for a second child.
No, and
Sometimes
PID, there is any, if there is if there is something pointing towards PID, or also, whether the first conception, the child was it a spontaneous conception, or was it also whether this endometriosis, adenomyosis problem is long standing, it could point out to that, whether the first pregnancy was also after treatment. So from that point of view, I would like to ask, and always, if there is chronic pelvic pain, it is must to ask about any kind of vaginal discharge. It's very, very important, because, apart from having other things like urinary symptoms or
I'm
GI,
sure you.
and she could still have a pelvic infection.
Yes.
So
I
basically,
think
you have to rule
Pragya
out
is right.
pelvic inflammatory disease in such patients,
Yeah, it's
because
very
there are.
common. Still, we get sometimes tuberculosis are like chronic pars alpins. Still, we get sometimes. So this is very important point that Pragya has raised. Yeah.
Now looking at
Did
her
not
previous
say
history of
I did not mention tuberculosis, because in the history it gives that there is no major medical illness in the past. That's why I refrained
nonetheless,
myself from talking
we have
about.
to always
But
rule
that
out.
tuberculosis boss is also logged in today, Dr. JB Sharma.
Okay, Dr. Meena, since
how-
she has given us a
I would
history
like
of
to add
recurrent.
one point. Can I?
Yes, yes,
Yes,
So
please.
whenever there is a pain which is increasing with filling of bladder, there are two,
Yes.
diagnosis, or you may think about. One is bladder pathology. Another one is adenomyosis. It is very, very common with adenomyosis, because the adenomyotic uterus itself is having that kind of turgid kind of pathology, that whenever the bladder which is in front of the uterus gets filled up, there is further pressure in the area, and that's why she has severe pelvic pain, and which gets released after she evacuates her bladder. So it is a very typical pointer towards the diagnosis of adenomyotic uterus as well. So we need to rule out these two
That's why
pathologies.
it's enigma, because all these things can lead to similar type of pain.
Yes,
So I think thank you, Dr. Neeta, for that. And
Yeah.
Dr. Meena, I want you to ponder on this slide, that is it really needed at every single episode of urinary symptom to rule out UTI with the culture?
So, ma'am,
And
in
if
this
so, why?
particular case, 36 years, I would have also taken a proper history. Like to add on with this, that is the bladder diary. Taking the frequency volume chart at least for 3 working, including the working days as well as the leisure days, as well as a food diary, because any food which is aggravating also I would like to consider the spicy food. Also in relation to the sexual activity, that also I would have taken, and she has had recurrent UTI, which she has not treated at all. At least one episode of evaluating her with the urine routine and urine culture and giving her a proper antibiotic is also important. Now, may not be a
And
repeated episode of.
Dr. Meena, sorry, I'm interrupting you. What I wanted to ask you is, she's been having recurrent urinary symptoms of frequency urgency. And what probably she did is, over the counter, she's just taken antibiotics and she's felt comfortable for a while. My understanding that with such a history, as a urogyne, is it right for us to tell the patient that every episode that she has a UTI, she must rule out an infection before she pops the antibiotic?
Yes.
Absolutely.
Yes.
Yeah, because what we are seeing that because in India we get antibiotics outright with no
Yes,
prescription,
right,
people are
well.
just, before coming to us, they've already had a course of ofloxacin,
Yes.
they've
Even
already
higher
had a course
antibiotics.
of
They use
nitrofurantoin.
the higher
Important
antibiotics
in
from
the
outside.
history.
Yeah.
It's
So
important
that
to
is what
note
I
down
wanted
if
to
she has
put it
taken a.
across.
It is
Yeah.
important to note whether she has taken a complete course of antibiotic or just taken
Absolutely.
over-the-counter
Absolutely.
medication in the case like ours,
And probably
where
not
she has
even
taken
completed the
over
course.
Yeah. So it is important we rule out what is the organism and give it a complete course of antibiotics.
Absolutely. And every single episode of any urinary symptom with a patient who gives a history of chronic pelvic pain, we must rule out urinary infection and we must ask her to clean herself well and ask her to get the midstream urine, which is very, very important to get an understanding of infection. So I think, Dr. Meena, I think this part
Dr.
is very
Vidya,
clear.
can I add something, Dr. Vidya?
Yes.
Yes.
Please do so.
Yeah, the thing is that any time a woman has a UTI, and like you're giving her, say, a course of whatever sensitivity comes as, nitrofurantoin or, levofloxacin for 7 days. It's very important that, we repeat midstream urine for culture and sensitivity.
100%.
Because many a times what I've seen, people have given a course, but they have not written her up for a repeat culture.
Yes.
So then what happens that, because it's untreated, we don't know whether with your course of 1 week, whether it's been treated or it's not been treated. So first and foremost, it's very important that every time a woman has a UTI, always, repeat culture after 10 days or so. So that, at least, if you treat her properly, then she may not
So we need
turn
to
up every time with
understand, Dr. Pragya, that the next episode is not with the same organism. That's very important because maybe we've treated her for E. coli and this time she comes with Pseudomonas aeruginosa. So it's very important to know that the infection is not by the primary organism and it is with the secondary if she has another episode. So whenever a patient completes
but
course of
it's better once she has received a whole course of antibiotic, at least after 48 hours of last dose, she should have had urine culture done. So that
usually, madam, 2 weeks is what we suggest.
Sterile.
Yeah,
So
2
now,
weeks is what we suggest.
Sorry,
so now-
madam. Can I interrupt? The
Yes.
repeat
Yeah,
routine culture is required only if patient is symptomatic. If she is relieved, the protocol says that we don't need to test again because we are not never treating asymptomatic patients. So if you are talking about the protocol says we need to treat the said episode of infection, and if patient is completely asymptomatic, we don't need to repeat test.
Okay. So it's
In case
okay.
she comes with again frequency and urgency,
then
then we must
get culture done.
Yes.
Otherwise, no need to get
So
culture.
the relapse is there is recurrence or relapse. Relapse means this patient is not being
like to add.
Yeah, she's not been
the
treated.
relapse. Yeah, and recurrence would be if after 2 weeks patient is having symptoms. Within 2 weeks, if patient is having symptoms, that is relapse, and probably that could be either the antibiotic has not reached the organism, if the same organism is coming, and if it is recurrence, then probably or this could be another infection. So we have to rule.
Okay.
Yeah.
So the message.
I think Dr. Amita said it very clearly that in recurrent UTI, we must rule out whether it is a relapse or a recurrence. Yeah, Dr. Anita.
I would like to add something more. That is, in our now, because of severe antibiotic resistance, which we are seeing over because of the over-the-counter prescription or inadvertent use of haphazard use of antibiotics and all, the antibiotic stewardship program is suggesting us that we may not give the treatment for prolonged duration also. Only if there is a chronic issue, then only you need to do that. Otherwise, patient can be treated till she is asymptomatic. There is now, they say that you may treat the patient only for 5 to 7 days, not even 10 days. That is not required. The antibiotic stewardship program is very, very important because in future we may not have many antibiotics to prescribe.
May not be an antibiotic. Okay,
Yes,
Dr.
yes.
Sharma, I'm sorry, since you are there, do you want to say
You want
anything
to
about
add
the
anything?
antibiotic?
JV Sharma sir? So
About
lots of
UTI,
discussion
no?
on UTI and
Yes.
antibiotics. Now what do you say?
Yeah. I was
Let's
listening
close
very
it with you.
carefully. I mean, I think so much has been said about the patient as well as about the UTI, and Amita Jain has clearly highlighted. But Amita, this patient never had any urine culture done. So that is absolutely wrong. We must do, because he has been
Yes.
getting unnecessary antibiotics without confirmation. So either we are giving her antibiotic without UTI for something else, or we are giving
Yes.
her wrong antibiotics. No, so we have to do culture. And in such a patient, when she has had 10 attacks of this thing, so I think even repeat culture has to be done, so to ensure that she is totally free from this infection. And then because she has got 8 to 10 attacks in a year, this patient is suitable possibly for prolonged suppression, like, you know, if the bacteria is sensitive to nitrofurantoin spores, so we can put her on after treating her. Like, I'll do her culture now, and I'll give her 2 to 3 weeks course of spores is sensitive to nitrofurantoin. So full dose of nitrofurantoin, and then repeat culture till she becomes negative. And then I'll put her on suppressive therapy for maybe 6 months or so, because she has had 10 attacks or so, if it is proven. Otherwise, if it's not proven, then she already has got endometriosis, so probably diagnosis may be related to that, not to
Yeah, the
UTI.
diagnosis,
So that is
if
important.
it is because of UTI, then only. Otherwise, if
Then
it
only,
is
then only.
because in chronic
Madam,
pelvic pain, we don't know whether this is because of urinary issue or something else.
Now we should move. So the
Okay.
after
And
restraint
also one more thing, ma'am, to add, as TB, tuberculosis, a national disease, if it is recurrent also, sometimes this evaluation may help.
Yes, 100%, Dr. Meena.
from head to toe
Absolutely.
everywhere in India.
You mean bladder TB?
Yes.
Dr. Meera, are you thinking of bladder TB or genital TB?
Genital tuberculosis is common. I think genital tuberculosis is common. I don't know.
Tuberculosis.
I think we can move ahead now.
But Dr. Kavita and Dr. Vidya,
No
I
one
would
is
again
allowing
like
you
to
to move ahead.
re-emphasize just
Okay.
one
Yeah.
line I want to say. Just
Yeah.
one
Yeah.
line, because somebody said that repeat culture, not Dr. Sharma, but someone else said that repeat culture based on protocol, it is not required if the patient is asymptomatic. But I feel, as I said earlier, that because it's not an expensive investigation. I mean, for at least I do write up for a repeat culture
I agree,
for
Dr.
every patient.
Pragya. I think you're right and you're valid for what you
At
think.
least for this
because,
patient, it should be done.
Yeah, it
Because
should be
he has
done.
repeated.
Yeah.
Can I add one
Absolutely.
more
And as
point?
Dr.
Can I
Sharma
add
was
one more
saying,
point?
as Dr. Sharma was saying,
Who is this?
nitrofurantoin somehow in our part of the country is not like, generally in India, we don't use it that much. But in the West, any case, if a patient comes with urinary tract infection symptoms, they straight away, like in UK, USA, they will put her on nitrofurantoin. And as Dr. Sharma said that, and then they would do a culture, and that's
But I
what
think,
they
Dr.
do in
Pragya,
the...
I think people have moved from ofloxacin to nitrofurantoin now. So I think we have also taken it very well from the Westerners that
Now
we
they are
need
taking cranberry
nitrofurantoin.
juice also. Cranberry juice is also good in cases of recurrent tract infection. So many companies are making and they are taking. So now,
Okay.
the woman has been examined, her vitals is stable, but she appears irritable, fatigue, and there is mild pelvic tenderness, but there is no any organ enlarged, like liver, spleen, everything is normal, even uterus is normal. And during pelvic examination, we found that there was cervical motion tenderness and some posterior fornix nodulatory was present. Also, uterosacral ligament was thick and slight resection in the mobility was found. And the distal examination showed hypertonic levator muscles and trigger points were lateral to introitus. So this is very important that levators were hypertonic and the points were lateral to introitus. Sacral leg joint tenderness was also present, positive, and there were no dermatomal deficits. So neurologically, she was intact. There were no any neurological deficit, but these findings were there. So what is the most important test that help us in diagnosis and avoid? Dr. Monica.
Madam, we are not able to see the slides.
Okay.
Can I add one examination point here?
Yes.
Yeah, please. Please.
Yeah. Here we have not mentioned about anterior pharyngeal tenderness, which is very, very important, because if
The
we are
bladder.
Dr. Neeta, I'm very happy that
Normal. There was no tenderness in the
possible
phonics.
PTU.
Dr.
These are the
Neeta, I'm very happy that you pointed out this. This was not mentioned on purpose,
Yes.
that we have experts who can
Yeah,
help us.
it is very, very important. No one checks that.
But madam,
Yes.
these are positive.
Trigonal tenderness, suburethral para. Very important.
Madam, these were normal. That's why it's not has not
No,
been
we
mentioned.
have to mention even if it is
May I come in,
normal.
ma'am?
That
Dr.
means
Neeta.
we have
Neeta, you're
ruled out.
right. We have to
Ma'am,
rule out
that is
anterior,
the
vaginal wall tenderness, and this was not mentioned on purpose because we wanted to know that experts are pointing out these things. So thank you very much
Yeah.
for pointing it out, and it was
So
really
they're
good.
testing us, Dr.
Pariksha
Neeta.
में
Yes,
हमारी
yes,
परीक्षा हो रही है.
yes, yes. Otherwise, what's the point of having experts? Yeah. So I think you're correctly right. It was missed, and we only looked at endometriosis. Now we are actually coming to the other part of the case. That is what we are trying to say as gynecologists.
So, yeah, ma'am. So,
Yeah.
as I can take it now that it has, we are all experts are very enthusiastic about adding on to
Yes,
the thing.
yes.
But at the same time, ma'am, I would like to add that the very fact that you've mentioned that pelvic floor digital exam had hypertonic levators, trigger points, lateral to introitors, that in itself, I mean, from at least from now on, from this webinar onwards, everybody should take it a point that there has to be a systematic examination of,
Yes.
floor, because, and that will anyways cover the interior fornix as well. All
Yes.
the tender points, the trigger points,
Yes.
the finger goes in a circulatory motion, and
Yes.
Amita had very beautifully shown that
Very beautiful.
slide.
Yes.
Yeah, so that itself is a comprehensive test, and if everybody is doing that kind of test, then we don't have to mention separately that anterior pharyngeal tenderness or maybe posterior or a pelvic floor or that way, because then that is my answer. A good comprehensive pelvic floor examination, identifying the typical tender points, and as we can see here in the examination, musculoskeletal system is also involved. So this appears to be an overlap. And also, if we find any tenderness in, as madam mentioned, in the anterior fornix and all, we really need to be very wary of the fact that there may be bladder involvement as well.
Yes.
There can be three overlapping things. We might have a uterine cause, we might have a myofasciopelvic involvement, and of course, we cannot forget our good old bladder. And there can be an interstitial cystitis component. So keeping
I think
everything in mind, the examination should be
Or
comprehensive.
maybe bladder endometriosis.
Yes.
Yeah, you have to rule out everything.
Absolutely.
But I
Yes.
think Monica, Dr. Monica said very rightly,
Yeah.
you have to have a complete understanding, and it has to be a stepwise examination. So you must have a diagrammatic mapping of the pain. A diagrammatic mapping can help us to tell the patient what is her point, and that will also help the future with a physiotherapist that we have already done the examination. Otherwise, patients don't like to be continuously examined, vaginally to trigger the whole thing of pain. So we have to have minimal examination where we can give maximum understanding to our referrals. Okay.
Madam
The
Vidya,
second question,
can I add one more thing?
Yes, madam.
Dr. Neeta, you're all for it. Come on.
So, in today's time, for those who are new entrant to the practice, what I've seen is they are very much dependent on sonography. They
Yes.
don't examine the patient. Can you believe it? They don't put
Hmm.
fingers in the vagina and they want to diagnose. So, I want to tell those
This is
that
a take-home message
please,
to the youngsters.
younger generation, that examination cannot be replaced by any other modalities.
Yes.
And that is where you win or lose. It is
and
the
especially
point
in a
where you either win or lose.
Yes,
Please
and
don't
especially in a patient with
escape
a
from
pelvic pain.
examination.
Yes,
Yeah,
madam.
yeah,
So
absolutely,
now
madam.
move on. So, Dr. Anil sir, Dr. Anil Pandey is there. Can we take
Yeah,
this?
Dr. Anil, we need you here now. We need you
Okay.
here now.
Okay,
So
okay.
we have
Now
to, he's there, he's there.
know the dermatomal distribution with regard to pain. And have you in your practice seen patient with chronic pelvic pain with
I think his
that
one
is
slide
all that?
showed it.
Yeah.
Yeah.
So, Dr. Neil has shown, but still we are asking if he is present there, please answer.
Yeah, it is. Am I audible?
Yes.
Yes, sir.
Very much.
Yeah. So
Very
now
much.
the issue is very simple. I made it very, very clear that the piriformis and that is the non-disc sciatica and the sciatic pain has got very clear dermatological differentiation. Although there can be overlaps, but then pain which is coming to all the toes, that is more of a compression at the by the piriformis. When it is coming to a medial toe alone or to the lateral, so L5, S1, this is more common in the disc sciatic pain. And just to make a point that the dermatomal distribution, I mean, all of you are fully aware of the legend of the blind Indians with the elephant. So each one of us look at it from our speciality. So from your discussion, which I was seeing, my entire focus was on the sharp pain which that lady had, 4-year duration pain, which was it was some sort of a visceral pain. And also she had some frequency. So when I see bladder, I see this, I am reminded, in our experience, we suddenly see patients who only have bladder symptoms and they have a large conus or epiconus lesion, which is sitting there, which is only causing this and not causing any radiculopathy or any myelopathy whatsoever. That is number one. So bladder, once it is involved, it and repeated UTI can also be part of the pudendal piriform issue. So these are the things I would like to say, that definitely this is most probably more likely to be from the gynec point, but from the neurological point, I would definitely like to evaluate why the bladder, why 4 years of pain. And so you will be really surprised that chronic constipation, and then you image the patient, there will be a large, huge presacral neurofibroma or a schwannoma. So it is very, very common. Thank you.
Yeah, so I think there is a primary insult which we need to, get into and understand. Okay, can we go to the next? Thank you, Dr. Anil. I think you elaborated it very well from your perspective, and we must look at the neuro or the dermatomal origin also.
Everything should be multimodal, I think, disciplinary approach.
Yes,
So now
yes.
she has gone investigation, her blood profile was normal. A125 was mildly raised, that is 33, I think it's normal. And TVS sonography showed bulky uterus with adenomyotic features, and ovaries were adherent to the uterus, though not very large, but it was closure like kissing ovaries. MRI was done, which also suggested bulky adenomyotic lesions. Rectovaginal nodule was present, ovaries adherent. So now next, what could be the possible differential diagnosis?
Dr. Neeta, I think you are the right person to help us with this.
So I was suspecting adenomyosis, of course, and I would put more, of course, it is deep infiltrating endometriosis, as it shows that there is a rectovaginal nodule as well, and ovaries are adherent, and there is adenomyosis, means whether endometriosis, interna, that is the adenomyosis also. So the whole spectrum of endometriosis is present in her. With the past history, this time maybe it has come with vengeance, and maybe it is more severe form, and that is why she is suffering. So would
Dr.
like
Neeta,
to...
would you only confirm it as endometriosis and adenomyosis, or with the examination points that were covered up, would you also put other points, other diagnosis?
Differential diagnosis.
Or you only
Of course, the CA125 is raised, and also MRI and sonography is telling us the same. So I think that is I would also like to see with the contrast whether it is involving the ureters or any other tissue or not. That we have to find out.
We have to look at adhesions. She could be having dense adhesions.
is only 33. It's not.
Yeah, but it is still on the upper side of the normal. 35 is the reference range, but it is still on the upper side of normal.
Yeah, but
So,
it is kind of not direct evidence, but
yes.
it is an indirect evidence.
JB sir, you
Dr.
want to
Yes,
say
ma'am.
any
Dr.
differential
JB.
Yeah.
diagnosis?
Yes, I agree, madam. This patient has both adenomyosis and endometriosis. Here, I want to say that if you were planning to do MRI, there was no need to do ultrasound for her. I think one investigation modality, endometriosis,
So
MRI
basically,
tends
sir,
to
after
give
an
most of the
ultrasound,
information.
But I would do
yeah.
ultrasound in anyway, sir.
Sir,
Sir,
actually,
ultrasound
with
Both.
the
You do both
gynecologist, our
ultrasound and
first
MRI both.
primary, this is ultrasound.
sir, ultrasound तो should be done in every
अपने
clinic.
चेम्बर में ही हो जाता है ना.
हाँ, ultrasound तो हो जाता है ना सर, इसलिए I think TVS ultrasonography is enough to diagnose adenomyosis. So many
So
features.
basically, as a gynecologist, it is an eye to all the gynecologists that a
Yes.
basic ultrasound is a need of the hour. And when we see any patient with this kind of a picture, we must rule out MRI, especially for deep
Okay.
infiltrating
Yeah, so for
endometriosis.
screening, you do ultrasound
Yes,
and then for
yes,
confirmation,
yeah.
MRI. Okay, I
And
agree.
also when we have a patient who's undergone endometriosis, cyst excision with chocolate cyst, there are a lot of adhesions and sometimes adhesions can be dense. And here you can see nerve entrapment and that could be pain. So the pain pathway where the nerves are going through, sometimes endometriotic tissue can form scars and these scars are very dense and they actually give the pain to the patient. So Dr. Meena, would you like to add anything further in this?
Dr. Rama is raising hand since long. Can we ask
Yeah,
her
Dr.
what she
Rama,
wants?
what would you like to
say,
ask, Rama? Dr. Rama?
Yes,
Unmute. Yeah.
yes, ma'am. I have encountered a special case of this type of pain. Patient was treated by many urologists about recurrent UTI, and she had a hernia in the labia majora.
Oh,
I examined her 3 to 4 times, but I also missed the diagnosis. But once she told me कि मैं जब बैठती हूँ तब मैडम दर्द होता है. Then again I examined her. It was a hernia in labia majora and it was creating the pain. And when she was operated for that, then she cured. It is a very rare finding, but I want to share with you.
Thank you. Thank you so much,
Thank you
Dr.
for
Rama.
That
It was
gives
very
the
nice.
importance of in a comprehensive examination, Dr. Rama. That's why we really need to be wary of the facts that various pathologies can cause chronic pelvic pain.
Yeah, so careful examination, clinical examination, as someone said, has to be done for all these patients, followed by ultrasound, especially 3D, and if need be, then MRI.
Everywhere
So
it
this
is
our
missed.
patient
In
has got
MRI,
deep.
in ultrasound, it is missed everywhere. Only
Yes, sir.
No,
examination.
examination has to be done, madam. Maybe in standing position also.
Can I add one more thing?
Yeah.
Yes.
Yeah. So here the importance of dyspareunia. It can be because of a deep infiltrating endometriosis, but also because she has not been given attention by the husband, due attention, what she really needs to,
So Dr. Neeta, yes,
and
we are covering up that topic because what you said was absolutely right. So basically, she is anxious, she's irritated because now the psychological component, so that there
also
is
is adding.
central sensitization, and that is all working on her mind now. So we are going to come upon that now. So I think we have given a good differential diagnosis looking at the overall picture. So imagine in a multidisciplinary team, what all we need to look into with a patient of chronic pelvic pain. So it is not just the gynecologist, but a urogyne, a pain management, a neuropsychologist. Everybody has their role. And it's so vital for a patient to be referred at the right time to the right fraternity. Madam, can we go to the next one?
Madam,
Dr.
I would
Meena,
like
would
to
you
add on.
agree?
Yes,
Yeah.
yes, ma'am. I would agree. And also, I would like to add on as a urogynecologist to add on with the interstitial cystitis, the bladder pain syndrome as well. And she has had a vacuum delivery, could be a pudendal neuralgia as well as a psychosocial factor. She has been left from the family. So
Yeah.
the psychosocial factor also,
Veteran
has to be
syndrome
kept
also
in mind.
because hypertonus muscles are hypertonus, there are trigger points. So I think this is also, this can also be cause of pain. So what are the
So now we come to a provisional understanding that probably she has deep infiltrating endometriosis with contributory pelvic floor myalgia or hypertonicity. I would say more of a hypertonicity due to the chronic pelvic pain that the patient has been experiencing. Now we also have to look at the bladder, but probably sometimes, as most of the gynecologists are so much into endometriosis, we probably may be missing. And this particular case has been missed with the bladder, which we will cover up in the next slides. So, madam,
Can
we'll go
I
to the
add
next
to
slide.
the diagnosis?
Yeah, we can add it. We can add it. But let's go on with
I
the
want to add here adenomyosis. The diagnosis, not only deep infiltrating endometriosis,
but
plus
adenomyosis.
adenomyotic
Along with
uterus.
adenomyosis.
Yes.
Absolutely.
Yeah.
So
Yeah.
let's
For
put
symptoms are
adenomyosis with deep infiltrating endometriosis with pelvic floor hypertonicity.
Yes.
Okay, next
Yeah.
slide, madam.
Yeah.
So what will you
So,
use?
Dr. Monica, as a gynecologist, the patient has come to you, and how would you go ahead with this?
Well, as regards the provisional diagnosis, as a gynecologist, definitely I'll go in for a confirmation of my diagnosis first.
Mhm.
It has been confirmed.
Dr. Monica, you're
Well,
muted.
MRI has already been done.
MRI has been done. So now what
Yeah,
we will do?
so-
Well, will you
so-
start?
So to add the adenomyotic component, as ma'am said, I would definitely like to confirm first. Yes, and after having evaluated the comprehensive history, that if she has not already had taken any kind of treatment for suppression of endometriosis, I would initially like to start with that. So in our armamentarium, we all know we have, oral contraceptive pills and then, progestogen agents like medroxyprogesterone, GnRH agonist can be used, and a newer kid on the block, which is specifically with the pain component, the elagolix we can use.
So I
But
think,
having said that, as a urogynecologist now, I would also like to, evaluate her on the aspect of interstitial cystitis. Because
Dr. Monica,
Yeah.
we'll cover that part later. We
But
want
I-
now only the gynecological perspective on this particular case. I think you covered well that we must
Yeah.
always look at the conservative management with medical suppression. And now with the GnRH agonists come in the picture, I think most of us would like in such a severe case, not necessarily all endometriosis, but of course the grading of the endometriosis is very important. Kissing ovaries comes in grade 4, and I think yes, we should look at it.
Yeah, why
I make
won't
a
you give?
point, madam.
Won't you ask the patient whether she wants to further conceive or not? She's already
100%,
undergone one surgery.
100%. Dr. Neeta,
Why
you're
you
always
want
nailing
to
the right
give
things.
medical line
Yes,
treatment
yes,
in
yes.
grade
Dr.
4
Neeta, we need
endometriosis?
that for
But
me.
Dr. Neeta,
I
Yeah.
thought
we
Dr.
need to
Neeta
take
will
care of the
want
pain.
that for me.
Dr.
I
Pragya,
will
Sorry, I
not.
shall
Can
have to
I,
leave for
can I
another.
just make one point, madam?
yes, yes.
In line with Dr. Neeta's thing where she mentioned about adenomyosis being a factor, it's in fact a stronger factor than
Yes, yes.
endometriosis than pain. So letrozole, which is a selective estrogen receptor modulator, is one of the newer, in the sense, newer uses of letrozole, especially for adenomyosis related pain.
Long-term
If you
uses.
are a
With a better
patient,
side effect profile than the GnRH.
Dr. Latika,
if
I
you
would
are
like to
a
just
patient, you yourself is a this patient, and you don't want any more pregnancies, what would you do with your own self?
No,
No,
I'm not
Dr. Neeta,
discussing
we have to understand that right now she's come with pain as her main symptom. You need to give her realistic goals. And yes, you have to address her fertility. That is 100%. So fertility has to be spoken to her, but she has come only with pain for us. So we definitely have to take care of the main symptom that she's approached us with. Fertility will be
She is
secondary.
already depressed, you won't be giving her elagolix. Because she's already depressed, and elagolix will further aggravate her depression.
Yes, Dr. Neeta,
And
that's what I'm saying.
I
Here is
would
the picture.
maximum what I would give is only dinoprostone, nothing more than that.
Okay.
100%. Dr. Neeta, we have to look at the scenario in a larger way because here we are looking at multimodal, multidisciplinary team. So we are not just going to act on her, we are going to now do referrals. And that is why this.
Vidya,
Yes.
faster.
Ghumega patient.
Okay.
What would
Chalo,
be
let's go to the next.
scenario, Dr. Pragya, Dr. Monica?
Yeah, Dr. Vidya, I would want to say that, in the list of, if you just go back in the list which you have shown, just previous, to all the Dynogest one and OC pills.
Yes,
That one. So, I think one more drug should be added, which is dydrogesterone. because dydrogesterone is also one of the very old drugs for endometriosis. And actually, the fact is that it is the only drug which does not suppress ovulation. Because all others like GnRH agonists, elagolix, OC pills, they would all, even with Dynogest, people end up with amenorrhea and all that. So dydrogesterone is one drug. I would just suggest that you add to your list.
100%. Yes. Thank you, Dr. Pragya. I think that was a good point that you covered up. So I think overall, let's just conclude with the gynecologist. The role of gynecologist is, yes, we have to always look at the conservative management. Whether she needs a laparoscopy, question mark. Who would like to answer this? Dr. Meena, would you like to go in and
I
It
personally
may not be a diagnostic imaging method, but if there is a negative imaging, we can go on with the laparoscopy, and that too if there is a skilled person to do a removal of the deep infiltrating endometriosis. That would be a ideal treatment if it is diagnosed with deep infiltrating endometriosis. The laparoscopy really helps there.
Okay.
Okay, what we have long-term fertility plans? So, Pragya, how can we help if she wants further baby?
Fertility.
Yeah, fertility plans. So,
this again, so here the role of laparoscopy comes because you can not only check the pelvis, treat endometriosis if there is a recurrence, because she does have a past history of endometriotic cyst. She has been operated. At the same time, we can check her tubes also. So, and like, going further, I mean, in this patient, of course, before treatment, I would definitely check her ovarian reserve. It's very important.
Absolutely. I think that is most important.
before going for any treatment.
Count. Because if we have to do a cystectomy or something, then it can further reduce. So all that has to be explained to the patient from fertility point of view.
I think now let's come to the role of a physiotherapist, because we have realized that she has hypertonicity. So do we have Dr. Dipti? I think she had to leave.
Dipti is not there. So
let me
skip
just, I think let's not, this thing, we just conclude by understanding. Madam, go back to the slide, please. So what a physiotherapist's role is a comprehensive pelvic floor assessment, which is very important. And I think as Dr. Monica, Dr. Amita very diagrammatically made us understand how we should evaluate the muscular skeletal system. We need to educate the patient. What is the role of physical therapy is to down train, because she is hypertonic. We need to give her relaxation.
Don't need to do Kegel exercise in this case. We will not ask
Absolutely. It has
Kegel.
to be only relaxation.
This is very
And
important.
we have to re-educate her, because she probably has, like how we said, we need to know her posture, we need to know her gait. So she's adapting herself to a very comfortable posture, and we need to now re-educate her to change her posture, and that is what it is, individualized. You cannot just give her one size fits all. It has to be individualized program. We need to keep a follow-up, not just with her, but also with the referring doctor, because the primary gynecologist is also following up with her as the main person. So we need to keep reassessing her pelvic floor with every follow-up, her flexibility, a symptom diary tool, her pain scoring. Everything has to be looked into. And what is the functional goal? Her sitting tolerance, resumption of her intercourse, everything, return to work. So these are the important aspects that when we refer to a physiotherapist, we must take a follow-up from them as well as with the patient. Okay, madam, let's go to the next slide. I think, have we missed the pain management?
We can skip this question.
Slide.
Oh, yeah, I think this is now this question.
No, madam, go backwards, madam. Go backwards. We missed no, backwards with the pain. A little backwards. A little backwards.
This one?
Yeah. So here I want Dr. Anil to now just give us a brief understanding of cross-organ sensitization and central sensitization. So can you just give a quick understanding? And the role of hypothalamic pituitary adrenal axis in stress.
Gray, everything. Dr. Anil is there?
Yeah. Can you hear me?
Yes.
Yes.
I mean, every pain, whether it is an abdominal pain or whether it is a pain, a gynecological pain, pain is a pain. And this
Yes.
has got various strategies, and all of it reaches the cortex. All of it gets centralized. So there is no question about it. And that is why we, as a rule, as soon as the patient comes to us with an acute back pain or something like that, we first take off the pain by analgesics, by patches nowadays, which are the thing. We first take off the pain. Now, if you allow a pain to go on for 4 years, then you are triggering other pathways, and you are adding on frontal lobe effects to that. There is depression there, and then now you will have to add on antidepressants to the entire thing. So I think everybody, including gynecologists, everybody should be very, very careful that the pain cycle has to be, one, not allowed to start, and if it has started, to terminate it as fast as possible. I mean, concurrently treatment can go on. You go on with that, but you definitely do this. And one point else also I'd like to make is, which I see in a lot of gynecology patients, is post delivery or post pregnancy, they forget that even women need a strong abdominals. They forget that a woman also needs a very proper sagittal balance, and a lot of women keep on suffering for years because the anterior abdominal, and the collar weak.
Dr. Anil, you're not audible.
So I
Dr. Anil, you're not audible.
I would
Network issues are at his end.
Network issue. I think most of the
I
words
think
have been
Dr.
covered by.
Kavita, let's go further. Let's go further.
Just we want to know this question. So what we all were discussing. So, madam, after 2 months,
there
this
should be a
woman,
re-establishment in all these patients.
Yes.
This woman report that her pain is still persisting, especially when bladder is full. She gets relief after passing urine. She was treated for adenomyosis and endometriosis, but now sometimes this pain is unbearable and she rushes to void urine. Still there is leak sometimes and frequency has increased. That is, there is urgency and also there is increased frequency. So what can be the reason? What is the provisional diagnosis? So Neeta madam, I think already has been explained, but still.
I think, Dr. Neeta, you've already given an understanding. You wanted to add this. So would you consider this patient as an ICBPS or a OAB? Can you just give us a differential point in quick way?
Sir.
Dr. Neeta?
Neeta madam.
Okay, Dr. Meena, would you like to add this?
Yeah, whenever there is pain.
Yeah.
Am I audible now?
No, you're not audible.
Hello.
Yes,
Yeah.
madam.
So whenever there is a pain while the bladder is filled with, I'm not audible?
Yes, madam.
Whenever there is pain, when the bladder is being filled up and the pain increases till she passes urine and it is relieved after the pain is, after the bladder is empty. Hello.
Yes, madam. So this is
Yeah,
a case.
am I?
Case of, I see. Yeah.
So is it clear? Could I make a proper point? Yeah.
Yes, ma'am.
So in overactive bladder, it is
right.
only urgency and frequency. And sometimes if it is a wet overactive bladder, then it is you leak and there is incontinence. Otherwise not. And yes, cystoscopy will rule out. You do you distend the bladder, and then when you evacuate the bladder, you can see the hemorrhagic points coming up in the bladder wall, and that is the diagnostic of interstitial cystitis.
Okay, Dr. Sharma, would you agree with
Madam,
Dr.
I would
Geeta?
like to add on.
Yeah.
From the history itself, you would be able to pick up like
Yes.
SSS, sexual history. It will be associated with sex as well as a spicy food and also stress. So keeping a food diary will really help from the history to pick up points on interstitial cystitis. And examination
basically
per se,
Dr. Meena, what would be the cystoscopic picture of an ICBPS? Can you just tell us in 2 lines?
Yeah, that has been told by Meera madam. That is a Hanna's lesions. There will be peripheral
So there can be
vascularity.
Hannas and there can be non-Hannas, but there are
Non-Hannas.
glomerations that you're going to be seeing.
Interstitial cysts are not Hanna's lesions. There may be absent.
Yeah.
Yeah, so there may not be lesion and there may be lesion. Glomerulations with peripheral vascularity.
Absolutely, absolutely. I think that is the diagnostic picture of a ICBPS on a cystoscopy. Madam, can we just conclude with the role of a
Sorry to
urogyne?
interrupt you, ma'am.
Yeah.
Ma'am, time is up.
Okay.
Yeah.
Okay. So this
Okay,
last
so
slide.
basically,
Yeah.
basically we have to understand with the complete history, if there is an ICBPS, we need to validate, educate. Bladder diarrhea and food diarrhea, very, very important because they are the triggers. Medical management, always the first line. We have to go for amitriptyline, hydroxymirin, and then we should see the progress and follow. Need of hydrodistension. Madam, can you continue?
Yeah, so this is assess. So this is multifactorial chronic pelvic pain. Look beyond the uterus, ovaries, consider endometriosis, pelvic floor dysfunction, bladder, bowel, neuropathy causes. Listen, validate, and document. And early empathetic listening is very important, which improves patient trust and treatment adherence. Individualized approach. Every woman is different, and every patient is different. So I think we should individualize approach. Don't overlook pelvic floor myalgia. Coordinate multidisciplinary care, address sexual dysfunction openly, empower with education. So this is the take-home message.
So I think that, I think the take-home message is to validate a story and to never overlook symptoms that are overlapping. And we need to refer the patients to the right referrals so that, there is no time wasted. Otherwise, there is from diagnosis to actual treatment, patient take 4 to 5 years. So that is what we want to point out, that don't waste time. Immediately start referring to the right, and it has to be parallelly done. It cannot be done that I will treat and then the patient goes. No, it has to be parallelly done as a multidisciplinary team approach. So I think, Dr. Kavita, you can conclude the.
So I think this was very nice session, panel discussion. All the speakers, panelists, chairpersons, all were presented so well, and they are knocking me. They are also calling me that time's up. So thank you from the core of heart. Just I'm
Request the chairpersons, ma'am. Chairpersons of this session, Mandip Pal sir, Anil sir,
Anil Thakare sir, Dr. All the chairpersons who are present there, Dr. Sarita Balera madam, Dr. Srikala madam, Dr. Karishma, Dr. Dheera, Dr. Rajesh Kumari, everyone who were present, and I'm thankful to all the speakers who presented so well, Dr. Meera, Dr. Anil Pandey, Dr. Amita Jain, and Dr. Tanvi. So we all had very good inputs. We learned a lot. So thank you so much. Thank you all the specialists,
Thank you,
panelists.
everybody. Yeah, thank you, Dr. Kavita, for having us. And as a FEPA founder, it is so important for us to get a platform. So I'm really very thankful, and I look forward to having more collaboration with you.
Yeah,
Thank
sure.
you, Dr. Anil, for your input and all the
Thank you.
speakers.
Thank you, everybody.
Thank you so much.
Yeah,
Thank you
for
so
having
much.
us here, ma'am. And Monica, Latika, all. Thank you, Meena. And
Dr.
Nilima
Kavita,
and
I
ICOG
couldn't,
team.
I
I'm very much
couldn't refuse.
ICOG team. Yes.
I said I couldn't refuse you in spite of the fact that I've come to Hyderabad for this IHR conference.
Yeah. Yes.
Because you asked me, I just couldn't refuse. Thank you so much.
Yeah, thank you,
for all your
everyone.
inputs.
Vidya for preparing such a good panel, and Meena, ICOG team, support team, Dr. Neelima and everyone. So my heartfelt thanks to everyone. Thank you and good night.